Well, good morning, everyone. I'm David Cade. I'm the CEO of the American Health Law Association, and it's my pleasure to welcome you today to our Health Disparity and Equity in Healthcare Convener. I think that we all arrived today with an excitement and passion about this issue and can't wait to dive in. So let me introduce you to Cindy Reese, the President-elect of the Board of Directors of AHLA, who will kick off today's activities. Cindy is a partner with Bass, Berry & Sims in Nashville, where she works primarily with acute care and psychiatric health systems, physician practice management companies, and population health management organizations, among others in her practice. Cindy shares your passion and works with clients who are on the front lines addressing health disparities and inequities in healthcare. Cindy, the mic is yours.
Thank you, David. Good morning, everyone. Welcome to all the participants in and those who will later view the AHLA Convener on Racial Disparities in Healthcare. As some of you may know, AHLA has created a DEI hub on its website, which includes information to help our members and the public stay informed on the critical issues surrounding diversity, equity, and inclusion in healthcare, with the goal of providing in-depth analysis and furthering conversations necessary to facilitate change. We hope that the DEI Hub will be helpful to you. And as a note, the recording from this convener will be available on that hub as well. The moderators of the convener have spent the last several months working with AHLA staff to develop the critical topics to be addressed today and to identify thought leaders who are experts in their respective fields in public health, social determinants of health, and health equity. Today's participants are law professors, current and former federal and state government officials, and leaders of nonprofit and for-profit organizations that are making a difference in addressing healthcare inequities. The moderators will introduce the participants of each segment of the convener as their session commences. But I will now introduce our moderators, and then we will begin the first session. Drew Bhattacharya is the Vice President of Diversity, Equity, and Inclusion at Advocate Aurora Health, a nonprofit multi-facility health system in Illinois and Wisconsin. He co-drafted the System Health Equity Statement on COVID vaccine outreach and distribution and led the initiative that established 55 community-based flu clinics, providing over 7,000 vaccines in underserved communities. His work focuses on health equity and intersects with language services, data analytics, civil rights, clinical operations, policies and procedures, and community health and relations. Dawn Hunter is a deputy director at the Network for Public Health Law. Prior to joining the network, Ms. Hunter worked in state public health at the New Mexico Department of Health, where she started as a Robert Wood Johnson Foundation visiting attorney in public health law through the network. She also served as Director of Health Equity, Policy Director, and Deputy Cabinet Secretary. Vaughn Jacobs is principal and founder of Creating Equity, a global strategic advisory services firm that helps individuals and organizations design and implement simple practicals and solutions to complex problems. Through the firm's health services division, also known as Pharos Healthcare Consulting, Vaughn provides strategic and operational advisory services and support to healthcare organizations working in rural and other underserved communities. Myra Selby is a partner at Ice Miller LLP, where her practice focuses on advising clients in healthcare, regulatory, and compliance matters. She is the firm's partner in charge of diversity, equity, and inclusion. Ruqayya Yerbi is a professor at the Center for Health Law Studies, William C. Weffel Center for Employment Law at St. Louis University School of Law. She is also the executive director and co-founder of the Institute for Healing Justice and Equity. Professor Yerbi previously worked at the U.S. Department of Health and Human Services as an assistant regional counsel. And I believe we covered everybody. So we'll go ahead and get started with the first session.
Thanks, Cindy. My name is Vaughn Jacobs. Welcome you all this morning to this convener. We're going to start the day pretty straightforward. You know, I believe that you cannot solve a problem if you do not know what it is. So we're going to start by talking about exactly what is the problem we're all committed to trying to solve. Participants in this section of the convener are, I'm going to read these. Frances Crevier has been serving as Indian County for over a decade. She has served in various capacities, from clerking for tribal Supreme Courts and working for the United Nations Special Reporter for the Rights of Indigenous Peoples to representing tribes as in-house counsel and special prosecutor. She joined the Indian healthcare field in 2015 to advocate for better healthcare in Indian country, as well as educate tribal members and communities on their alternative healthcare options. She joined the National Council of Urban Indian Health in 2016 as the policy analyst and congressional relations liaison, and later became director of governmental affairs. As of August 2017, she's now the NCUIH's chief executive officer. Also joining us, Andres Gonzalez, vice president, chief diversity officer for Perpetuate Health. He is responsible for overseeing the integration of diversity initiatives throughout the organization, including expanding workforce diversity and strengthening community relationships. Frances Mills provides leadership for the Cleveland Office of Minority Health and the Healthy Cleveland Initiatives, whose programs inform, educate, and empower individuals, organizations, and communities on chronic health issues impacting persons of color. And finally, Professor Heather Walter McCabe holds a joint appointment at Wayne State University Law School and Wayne State University School of Social Work. Her research is done at the intersection of law, social work, and public health, where she translates complex legal issues and research findings across multiple professions to make the information accessible for use by practitioners and advocates in improving population health. Thank you all for agreeing to be a part of this portion of the program. I'm really excited to engage with everyone. And the first thing I wanted to ask is, let's get some common vocabulary. Like, what is the difference between bias, discrimination, and racism? And others on the convener, if you want to join in, please feel free to do so. I'm going to throw this first question out to Professor Walter McCabe. Let's start with a little bit of instruction, but you know, words mean things, and I hear these words used a lot interchangeably, but they are not the same thing. So I'd like to get your thoughts, sort of what's the difference between them, bias, discrimination, and racism, and maybe even a little thought about which of these or all of these are we really trying to address?
The phrase of 2020, right?
Yes. You couldn't have a virtual program without it.
Absolutely. So I just thought I'd get that one started out of the way, right? So I actually wanted to start with Dr. Camara Jones has a nice definition of racism. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and community, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And there are other ways to define that, but one of the things that I like about it is it talks about the impact on the whole community, not simply on, importantly, but not only on those impacted, to make this clear why racism itself is something that should be of importance to everyone. And it really addresses not simply at the individual level, but the structural level, how racism really makes an impact across the board. Mm-hmm. And so I wanted to start with that. And Dr. Jones has done a lot of work in this area, but I like that definition because I feel like it's very inclusive of the many facets of racism. And so that's it, and makes it also easy to think about how it impacts health and health equity. And so I don't know if others want to take other areas or if you want me to go on. Does anybody else want to do bias and discrimination, or would you like me to continue? All right. So hearing nothing, bias and discrimination. So bias and discrimination. Discrimination is more the actual action of when racism is played out in an interaction, and discriminating can happen at the individual level. And discrimination can also be part of baked into some of the structures that we see that disadvantages, and it's that part of racism piece that talks about the disadvantage that we see put forth towards impacted communities. And here we're talking about racism specifically against Black communities. I'm actually going to let one of the other panelists take bias because I've lost my notes on that and I want to make sure it gets its full due. Do others have a good definition for bias that they bring to the table today?
I don't know if Francis Mills or Andres, do you have something you want to share on that maybe?
Sure. So bias is the prejudice in favor of or against people or groups compared with another. Something that is really important, and it's part of the work that I lead here at Freighter in the Medical College and have done it for the last 20 years working in healthcare, is that as we do a little bit of level setting here, is the notion that we all bring our biases, right? We all have biases. And I think it's important, even for those of us who do this work professionally, to admit to that reality, because I think what it will do is it will minimize, right, and reduce some of the walls that might exist, right? And people might not be as defensive as we come to the table, right, to address or co-create the solutions that we need. But that's actually how we define bias here for our health network. And certainly it's one of the key areas that we are addressing, both from a clinical standpoint as well as from an educational standpoint, to ensure that our staff members understand what their biases are, and certainly that they're addressing that. So certainly that's not minimizing, right, the role that bias can play in the delivery of care to our diverse communities that we serve.
No, thank you, because I really do appreciate that. You know, some friends and I who do this work, we say, if you're breathing, you're biased. We all have these belief systems, right? We've all sort of put together this way we think the world works or should work, and we're all operating from that. So there's that individual component. Then there's, Professor, I think you talked about sort of discrimination being the actions that people take, maybe based on some of those beliefs about, you know, the assumptions we're making about people and what should or shouldn't be. And then racism being the structural, systemic sort of outcome as all of those things build on each other, right? And so when we talk about health equity in particularly and addressing disparities in healthcare, I guess that's really sort of the next question, right? I see those, you know, I see bias, discrimination, and racism as being juxtaposed against health equity. I don't know, Francis Mills, I don't know, maybe you have, you know, being someone whose job is really centered on this, if you have any thoughts about, well, what then does health equity look like when it's juxtaposed against these ideas of bias and racism and discrimination? Or is that even the right context for this conversation?
I think it certainly is the right context for the conversation. And I too have a huge respect for Dr. Kamara Jones and look at her definition of equity because it provides a measure of responsibility. It's the assurance of the conditions for optimal health for individuals. And so what health equity looks like is that when it comes to race or ethnicity or gender, poverty, sexual orientation, that those things do not dictate access to care, level of care, quality of care that individuals are receiving. And so when we get to a place where we achieve health equity, we'll see disparities begin to dissipate.
Okay. I don't know if the other Francis, I don't know how, I'm going to have to try to figure out how to handle both Francis, but, you know, given that, you know, you specifically serve Indian country and that being a unique setting, what does health equity maybe look like from your perspective? Or is this, you know, what does this conversation sound like in tribal communities? Is this something that is being discussed, addressed, and maybe talked about in a way that we aren't mentioning here?
Yeah, thank you for asking. So I definitely see, so in our communities, it's a bit different. The way we've prioritized is a bit different. And so in the Indian health system, we look at, I mean, equity does look different and priority looks different. For us, priority is prioritizing our elders, prioritizing our culture holders, our native language speakers. And so it does look a little bit different than it would in, in mainstream, I think, America. But I think in some of our facilities, I mean, we have Indian health facilities and they do serve non-natives, but they do prioritize the natives. And so I think that doesn't serve all of Indian country, but it does serve some. But I think, yeah, true health equity is to hopefully have access. I think access is one of the biggest issues that a lot of our communities together face the similar issues.
Okay, access. All right, so in thinking about sort of what health disparities look like and sort of the lack of equity in the healthcare system looks like, and all of the work that you are all doing to try to address that, I think about things like, again, the words that we use, diversity, equity, inclusion, and even something as, foreign or maybe even radical as justice, right? Health justice. And what are we actually aiming for? What are Andreas, in your organization, you've done so much work in sort of developing an infrastructure and programming. What are you aiming for as an organization?
It's a great question. I think I would say, so I'm going to start with the latter part of your question and we'll progressively work backwards here. So I think what we're aiming for is really to create or to ensure that there's health justice by way of delivering on our promise, which is our mission to provide both culturally and linguistically equitable care to our communities. So I think that that's really what we strive for. But certainly to your point or first part of the question, then it becomes important in terms of, well, then how do you define diversity and inclusion, right? To really build on that. And so I think that diversity and inclusion becomes the foundation in which we then build, right, towards creating health equity and certainly delivering, right, or ensuring that we have health justice. And so for us, diversity is being able to recruit. So from a recruitment, right, from a workforce standpoint, is ensuring that we are recruiting individuals from the communities that we serve. And we know, right, and there's data that shows that when you have individuals from communities, right, that are mirrors the communities that you serve, certainly you tend to actually have greater treatment adherence. Certainly you can shorten length of stay, right, because there's that cultural proximity that exists and understanding and cultural competence on how to deliver care for those communities that you're serving, including, by the way, language preference, right, and understanding the issues that come with our ability to ensure or not ensure that we're providing that linguistically capability to all of our patients. And so for us, that has become extremely important. But I think something that is extremely critical to also address is that sometimes we use the term diversity and inclusion interchangeably, or we think that because we have diversity, we have inclusion. And the reality of it is you can have a lot of diversity and lack of inclusion, or the other way around as well, where you can have inclusion, but of homogeneous teams, right, that are not diverse in essence, right? And so I think it's important to understand that, in order for us, again, to deliver on our promise and philosophy of health justice, yes, we need to actually make sure that we're hiring individuals that certainly mirror the communities that we serve. But as critically important, we need to actually create inclusion for them, which means that we are creating a culture, in our case, that is rooted in dignity and respect, where every single staff member that walks through those doors will know that, you are valued in this organization, your opinions are heard and will count towards the co-creation, right, of the solutions here. And it's part of the work that we have delineated. If I could actually provide a really quick example here, even with our business resource groups, where we have gone down this path of having affinity-based groups, where these groups are actually helping us to address complex issues in the organization and really addressing it by providing solutions that really meet, right, or can address those challenges that we're facing. And so I think that you cannot have, certainly there's no way that we can deliver on our health equity promise, right, and ensuring health justice if we are not certainly recruiting diverse individuals, but also providing that inclusion where we're giving them, right, ultimately that sense of belonging in the organization, where they know that, you know what, this organization gets me, I will be able to have a great career here, and certainly I am, the organization is appreciative of the gifts and talents that I bring. And so ultimately for us, diversity and inclusion are important, but they're the foundation in which we have built then our health equity, and certainly we deliver on our promise of health justice as well.
Okay.
And if it's okay to build a little bit on that, and when we're looking at health
Sure.
justice, I think that it is important to look at all of those issues within the healthcare system itself. And I think that when you speak about health justice, one of the things that it brings up are all of those areas with outside the health system itself that may actually impact even how people get to us, like environmental issues in different communities, or just housing issues and access to safe housing, even when housing is available. So I think that one of the things that, as I hear the phrase health justice and think about that, I think that particularly from the public health perspective, thinking about those broader issues that impact health on a daily basis and perhaps can even be a part of prevention before it becomes a problem, that if there were more equity and less structural racism in many of those systems, that we wouldn't see people coming to the health system itself even in the same ways. So I think it's important as a part of our discussion today that we particularly if we're thinking about it from a public health perspective, that we're thinking kind of broadly about some of these other issues, as well as the important issues which Dr. Gonzalez brought up.
I think you're making a really important point. Like, this is a very holistic conversation, right? You know, the work that you all are doing in this area is really about addressing the whole experience that we have as humans that impact our health, right? And this is where we got to this point. I was looking at some articles and I realized how many public health organizations, government organizations, academics have declared racism as a public health crisis for the very reason that it impacts the whole of a human being. And then it shows up in our care, centers, and it shows up in our hospitals and other things. But like you were saying, Professor, a lot of this is stemming from things that are outside of the care environment, that are really broader social issues that we have. And I think about, in Indian country, again, all of the things that create the environment within which tribal entities are trying to take care of their people, right? The infrastructure that has been lacking for decades and decades, that builds upon a lack of access, and then builds upon, people not being able to maintain preventative care and therefore having more complex issues. And then a provider walking into that, trying to figure out what to do. I'd just like to get your thoughts sort of on the idea of what it means to address racism as a public health crisis, right? Now that we've had people make this statement, well, what does that actually do? Does it do anything? Does it mean anything? Or is it just, for being, a little lack of cynicism, but, is it just a marketing spin for 2021? Who wants to hit that?
I'll hit that one. We're at a very interesting time in terms of these declarations that are being made all across the country. I know that Ohio is a state that I think we're up to 25 counties, municipalities, health departments have made such declarations, and they are simply an acknowledgement, which is very, very important in terms of you can't begin to fix what you can't acknowledge. However, there has to be substantive action that follows to truly address racism as a public health crisis. And one of the areas I know I can share in the Cleveland-Cuyahoga County area is that this whole discussion of how do we engage the community in the process. As policymakers and as leaders, sometimes we're often paternalistic in our application of what we think equity should look like for other people, instead of simply asking people, what does equity look like in your given organization, in your community, in your hospital, and moving forward from that point. That's a place where people really get uncomfortable when you talk about diversity and inclusion. You know, I always say that diversity is who's invited to the party, but inclusion is who really gets to the table, who gets to eat the party favors, who gets to really participate in the decision-making and planning process of what is going on in our systems. And so here in Cleveland, we're trying to specifically not just call out racism as an issue that must be addressed, but that it has to be done in partnership with the community and to purposefully elevate those voices so that we can move into the right direction, because it hits when we talk about health equity. You know, we're saying that we're making every effort to value all people equally. And so that's one of the first things you've got to declare if you're going to fix it. And you've got to include the impacted population and elevate their voice in the process, because it's addressing equity is not a project, it's not a program, but it's a process and an ongoing practice that is here and the past and the future all at the same time.
I like what you said about this not being a project. You know, I feel like we have a lot of conversations about DEI that makes it feel like it's, if we check these 4 boxes, we're done, racism's over, we're all good. I don't have to think about this or talk about this anymore. And what you're describing is a very different approach. Dr. Gonzalez, I don't know if you had anything you wanted to add here.
Yeah, I was going to say that I concur with Frances. You know, one of the comments that she made, and it's spot on, is, you know, I think that, you know, as I reflect on some of the efforts here, and actually Milwaukee mirrors Cleveland in many ways, we also have taken the same stance of, you know, certainly the city, the county, and a number of organizations as well, including ours as a health system, took that position of calling racism a public health crisis. But certainly, to Frances' point, it cannot just be flowery words. You have to back that up with actions. And I think that for us, it was really important to really understand and really engage the community in what we're calling community conversations. And so we've had them with the LGBT community, with the Hmong community, because we have the 3rd largest Hmong community here in our state as part of the resettlements back in the 70s, with our Latinx community, Black African American community. And one of the things that we learned is that, right, as we know, many of our communities, they know what the solutions are. They understand what the issues are. And so if we can come in with humility into this conversation, right, and engage them and build trust, then we are going to be able, right, to not only understand that and gain that insight, but then it's going to actually help us to understand what do we need to do as a healthcare system, right, to meet the needs of the communities that we serve. And so for us, it actually ended up, in terms of the actions that we took, to look at examining our own biases. We actually now have rolled out education for all of our staff, and not just in terms of just knowledge base or creating greater awareness. It's really about sustaining it in terms of behaviors and actions that we need, especially our providers, right, to understand and to sustain over time. It's also about our commitment, because we send the 1, 2, 3 for equity pledge from the American Hospital Association to understand, are we stratifying our data, right? And if we are, what is our data telling us, right, in terms of serving our communities? And we have found out that certainly there's a lot of disparities across the board when we're looking at whether it's diabetes management, whether it's cardiovascular issues, whether it's actually something as simple as readmissions, right? So for us, it has been really important to understand and certainly stratify the data, and then use the data to then guide us in terms of the opportunities that we have and solutions that we can create here. It's also about treating people with dignity and respect. And for us, that's foundational, that's paramount, because it's one of our, certainly our values. And then 4th is about leading change by addressing all of this. And Frances made this point that it's actually, you know, you're part of the ecosystem. So who else do you need to bring in, right? From a social determinants of health model as well. So we work with a number of organizations, community-based organizations, federally qualified health centers, to really address these issues holistically in our community. And I think that that has become the proven formula for our system and for our community. Last comment that I'll make is that we went as far as not only putting this right and making this commitment, this anti-racism an anti-racist pledge that we've taken now has become a banner that we have actually in all of our facilities. So it's a great reminder. And from an accountability standpoint, it's great that we have done that, because what it does is now it's holding us accountable to the promise that we have made to our communities at large, right? Whether it is our staff, whether it's our patients, whether it's a community at large that is coming through those doors as consumers, perhaps, right? Or just to visit family members or friends in our hospital systems. So that's part of what we have done here, and how we're seeing that it's playing a greater role and really addressing the issues in our community here in the greater Milwaukee area.
That's really good.
Sorry. I think that partnering both what the last two speakers have said, I think that those internal accountability mechanisms and bringing people to the table who are actually going to be impacted by policies. I think the idea, and I think that perhaps Dr. Mills mentioned this as well, the idea that the community be part of not only being involved, but at the table and even the agenda setting. Is really important. And I think that as we're looking holistically across many areas of health justice, really being mindful of that. And I think Professor Burris is going to be on later, but some of the models that he's put forth for doing transdisciplinary public health law really does recognize the need to have community at the table and thinking across many different areas, and maybe thinking differently about the way we've been doing policy. And I really think that as we are engaging folks in health law and public health law, really reminding and thinking about getting people to the table and not getting them to the table too late, getting them to the table so that they're the ones helping to set the agenda, and in fact, probably leading the agenda setting if we're doing it correctly and really want to be effective. And they can be experts at all levels of this, even things like implementation and evaluation. We can often see people in the community have innovative ideas about how to evaluate that we as traditional researchers may not even have thought of. And so recognizing the expertise that the community brings to the table, valuing that, and I think as many people have said, listening and then acting on it, not simply hearing it. So I just wanted to say, I think that both of what they've said can be both in the healthcare setting and without in those areas that impact health itself.
Yeah, I mean, I think what you guys are talking about is really powerful, because what I'm hearing is that this is going to require some organizational vulnerability, right? You're going to have to not be afraid of the word racism. You're going to have to not be afraid to bring people in when they tell you how you have not served them, how you have not met their needs, and not be afraid of that conversation, but be willing to engage in it so that you can get to the place where you build enough trust to be able to get input and design things that actually work. And I think from an industry perspective, and maybe particularly, I'm coming at this from the legal side of the house, that's a hard thing to convince people to do, right? It can be a hard thing to say, I need you to sit still here and let people tell you how you have not served them, even though you think you've been doing all these wonderful things. And that's not to take away from all the wonderful work that you've done. But the important part that we have to do right now is have this conversation. And from a policy perspective, as well as an organizational perspective, how do you get your leadership ready to do that? How, what does it look like to bring into your CEO or to, the head of your department or to the governor to say, hey, governor, I need you to sit still and listen to the people that you are supposed to be serving and let them tell you how their needs are not being met. Is that a conversation that happens, or are there, strategies and techniques that you all have used, because you've clearly found a way to have this engagement, but what did it take to get there?
I'll just jump very quickly and would love to hear from others here, all of our other panelists. But Vaughn, you're absolutely right. I mean, I think for us, it has been our CEO's willingness to be vulnerable, coming into the community and doing a couple of things. Number one, acknowledging the role that not only healthcare has played in our BIPOC communities, but more importantly, what Freighter has done, right? In terms of our own accountability. And I think that really has become critical for the community to know that, we're owning our own issues, right? We own the legacy of a lot of these issues that have permeated, Milwaukee. When you think about it, Milwaukee is the second most segregated city in America. And so we have a lot of issues here. And so certainly we can either continue to play that role, or we can be one of those change agents that it's willing to put right that stake, as we did, on really calling this a public health crisis. And if so, then what are we going to do differently and better? And so our CEO started doing that. And by way of acknowledging that and really coming with that humility into the community, it started actually then opening the dialogue. And as a result of then sitting around that table, right, not to speak, but to listen, then people understood that she was willing, right, to sit patiently, right, and quietly to really listen to what the community had to say, right, in terms of the issues and some of the solutions also that they have already co-created that certainly could be part of this, a new pathway in the future. And so that is something that she has done for us. And as a result of all of that, we have seen that we're gaining greater trust in the community. So now it's becoming more of a dialogue, and people are willing to engage with us in authentic dialogue, right? Those crucial conversations about, here's what needs to happen, or here's the issues, right, that we have been confronting. What is it that Freighter is willing to do, right, and own, and certainly also co-create with us as we move forward in this new, with a new plan and reality for our communities at large. And so that is something that our CEO certainly does. I'll mention one more thing, which is it's critical, right? Because it starts at the top with your leaders. And for us, our CEO treats diversity, inclusion, health equity, health justice as a key imperative for our system. It is actually baked into everything that we do, so much so that she actually chairs our diversity council. And so it's actually, and then we have also tied compensation to all of our goals and efforts. So again, what you do not track doesn't get done, and and so let's put also our dollars where our mouth is. And so that is something that our CEO has boldly done. And I think that has been also part of the game changer for us as a health network here.
I agree with Andres. It is the responsibility of our leaders getting them to the level of perspective transformation that they are willing to make that commitment and engage. And so one of the things that our mayor did was to require a certain level of racial equity training for all of his cabinet members, and how that training is filtering down into various offices and departments, but to really get leaders to see what the impact is to neighborhoods and cities or organizations. So the whole community is affected when we don't address health equity, when we don't address racial equity in the community. And so how we get there is really what's the bottom line in terms of dollars and cents? Because at the end of the day, we have to get to the hard place where we are doing that third thing that Dr. Jones talks about, providing resources according to need. That's the huge frontier that organizations, that communities, that leaders have to cross. How do we get to people to what they need based on who needs it? And so having those discussions about formula funding, having those discussions about COVID rollout and who gets it and who doesn't, those have been critical conversations that could not have happened if leadership have not had a certain amount of humility to begin to even see the whole picture about the cost of racism.
I don't know if anybody else here in the convener has anything they want to add. We only have a couple more minutes for this session, so I wanted to create that opportunity if anybody else had anything they wanted to share or add to this discussion.
I wanted to jump in really quickly. I had put something in the chat just about truth and reconciliation, but I want to piggyback off of what Francis said. It's not just about being honest, but it's also about financial support and investing in the communities and connecting that with whatever we're doing. I think oftentimes we think of health as being separate from economics, and it's not. And so if you want community to play a role in decision-making, evaluation, and giving them power, then you also also need to give them funding to respect the time, the expertise, and the creativity that they're bringing to the table.
Absolutely, absolutely. One of my favorite sayings is budgets reflect priorities. And so if you care about something, it's amazing when you can find money for things that you care about, personally as well as a society. We are at time. And so given that we have so much richness to go through all for the rest of the day, I'm going to honor that. But thank you all so much for starting us off in a really powerful conversation. I'm excited about what the rest of the day has to hold. Thank you again. And I'm going to pass it along to the next moderator.
Thank you, Vaughn, and what an exciting start to our entire convener today. I'm going to talk about an area that is a contrast, I think, to what we've heard. What we've heard from our first panelists is about constructing, about building. And now we'd like to turn to the question, how do institutional decisions perpetuate racism, perpetuate discrimination, perpetuate bias, and a lack of equity? And for this part of our discussion today, we're going to have a sort of wide open panel. So I invite anyone who is with us today to chime in on this particular area of discussion. I'd like to first maybe invite Rakia to talk a little bit about institutional decisions from a workforce diversity perspective.
Thank you. And I'm excited to talk about this. So I think one of the things that we don't consider as much is the ways that hospitals and healthcare facilities are microcosms of the greater community. And so when we think about equity, in terms of those institutions, we need to think about how they treat all of the people who work with them, particularly thinking about some of the low-wage workers and some of the independent contractors that work for them, and to ensure that they do not lack access to healthcare, health insurance, and can be healthy. When I was in Cleveland, we saw a few of the healthcare institutions really committed to this, including Metro Health, where they decided to pay for the health insurance of all their workers, especially the lower wage workers, to ensure that they also raise the minimum wage to $15, especially for, again, their low wage workers. And this is so key because we don't often take into consideration how these members are part of the community, that they oftentimes try to seek to get healthcare there. And that is a greater example to the larger community, how you treat your lesser workers. And I just highlight that it's not just, right, the people who clean, who serve food, but we often have to think about some of the traveling nurses who are a part of that. If these institutions have nursing homes or provide home and community-based care, that all of these people work within the healthcare structure and system, but often are at poverty level, can't afford insurance. And so that is another way to think about equity, that if we do not provide for these workers, then we are just perpetuating discrimination and unequal access to healthcare.
Great. Thank you for leading us off, Rakia. And what about inserting equity into decision-making across the continuum of care? I pick up on a little bit of what you said at the end there about, for example, in long-term care and a lot of facilities where much of the workforce is working at the very lowest end of the wage scale. And what we've seen during this period of COVID is that's the vector that's been most exposed to the disease, most exposed to the vagaries of employment and unemployment, and least protected. And so is that part of what you talk about when you say we really have to look at who is included in the community? And it is the people who work in the healthcare arena broadly.
Yes, and so I definitely throw it out to everybody else too, but I was able to write a paper around this, around nursing home care, particularly the disparities that we saw during COVID in terms of deaths, particularly in predominantly Black and Latino nursing homes. But then also connecting that with the workers, right? The fact that many of the workers were unprotected, didn't have PPEs, didn't have paid sick leave, weren't covered under many of the economic relief bills because they were exempted out, because there was a worry we wouldn't have enough people working in nursing homes and providing community-based care. And so we do not really hone in on this problem, and we don't keep track of the workers who have been impacted by COVID-19 in nursing homes and home and community-based care, even as we track the numbers of deaths of residents who were impacted. And so really ensuring that institutional decisions to move us towards equity include all the people within the healthcare system, including the workers, particularly the vulnerable who provide care to the most vulnerable in nursing homes and home-based care.
So how do we go about doing that? How do we go about inserting equity into decision-making across the continuum of care? We've heard in the first segment that a lot of this work has to start with leaders, start at the top, from Andres and others. And so if that is a given, how in the the institutional aspect of the healthcare system do we begin to move that needle? And I would invite anyone to chime in.
Yeah. Myra, I'll jump in here.
Sure.
Certainly, since you mentioned me here in terms of one of the comments that I made earlier, as I referenced in the first session, we have been, this has been a 10-year in the making, certainly journey for us. And we started, of course, with a diversity and inclusion journey that became really that foundation for us. And about 5.5 years ago, when I arrived here, is when we built the health equity, especially when we signed the 1, 2, 3 for Equity Pledge that actually has 4 key mandates, 4 key goals. One of them was actually around, collecting the data, right? The REL data that we call it, race, ethnicity, and language preference. But we didn't stop there. We actually ended up, collecting other data in terms of SOGI, sexual orientation, gender identity, also military veteran background of our patients, disability as well, because we understood that it was important, right, for us to really look at all the different dimensions of diversity. And so part of our journey has been looking at being very intentional and strategic, right? And looking through that equity first lens. And so part of what I will say here is that where you reside matters, right? Typically our function of EDI, equity, diversity, inclusion, tends to only reside or report into HR. And the issue with that is that then you become just a human capitalist by nature of that. What I love about Freighter is that actually I reside under the EVP COO of our system. So that allows me to sit around the same table with all the other chief officers and really have really great discussions around the work that we are driving collectively, right, as an organization, and then really helping and advising and also mentoring all of my leaders so they can start developing their own EDI right lens and or exercise those muscles so then they understand what's within my purview, how do I bake it in, and then how do we drive that, right? Ultimately, it really has to be woven into the fabric of the organization, into all the goals that you're driving, and then having very clear metrics. Because if you don't do that, then you won't know whether you're achieving the collective impact. And then ultimately then having, as I mentioned, the last piece for us was about 1.5 years ago when we decided to go one step further and then tie compensation into all of our goals. because certainly then this also now hits the pocketbooks, right, of everyone in the organization, and it creates one more level of accountability for all of our leaders. And so that's the way in which we have been able to weave it into all of our goals. It's actually part of the overall strategy. So there's no goal within Freighter and the Medical College that we have not thought through from an EDI perspective, and we have baked those elements into those goals. And I think that becomes paramount if you are certainly, again, committed and you're going to be driving a true equity, diversity, inclusion, and anti-racism strategy.
I'm wondering if we can hear from Harold, because I saw your comment in the chat, and you've got an interesting perspective also to bring in here.
Yeah, I put a link in the chat to an op-ed my colleague Amal Navatha and I wrote in the Times last year, where we looked at payment models. So as we just heard, there's a lot of potential for hospital systems within their own cultures to turn things around, but in many ways, they also need to respond to the incentive structures that are established around them. And so in many ways, we see good initiatives that try to reward not just piece rate, doing a lot of things, but try to reward value and focus on outcomes. But some of these proposals can have unintended consequences, in that you don't want to have a payment model that rewards you if you have low readmissions or achieve particularly good outcomes, if that then leads to shunning more complicated patients who, because of the consequences of structural racism, are more likely to be minorities. And yet we've seen that, and the link that I've sent you documents several studies that illustrates this. We've seen that happening. So what we suggested in our piece is, one, that we need to have a good sense of what's actually going on, because we don't. This is another one of those aspects where we don't deal with structural racism, where somebody just says, well, you're Black, I don't like you. That's a sort of dumb version of racism that I think is not very interesting, as appalling as it is. But we're dealing here with another form of basically unintended consequences, if you want to call it that, to not offend anybody. But I think in many ways, it raises all the same issues, that we need to understand what is going on. We need an actual review, a systematic review of those kinds of policies, and systems that enable us to have warning flags go up if it turns out that some of these models do have the consequences that more disadvantaged populations are shortchanged in the pursuit of efficient delivery of healthcare. So I think that's something where, whether legally you call it disparate impact monitoring or process evaluation in more health service research oriented terms, but something where we want to make sure that a major initiative that is underway that directs payments in ways that rewards good outcomes doesn't lead to more disadvantaged communities, and by implication, more minority populations to be shortchanged in the process. So I think that's another key part we really need to pay attention to.
Thank you, Harold. And I'm going to give a brief introduction, because you have not been previously introduced to our panelists. So Harold Schmidt is an assistant professor at the Department of Medical Ethics and Health Policy, research associate, Center for Health Incentives and Behavioral Economics at the Perelman School of Medicine, University of Pennsylvania. Dr. Schmidt's research interests are centered around improving opportunity and reducing disadvantage for marginalized populations in health promotion and healthcare priority setting. So
that's all correct. And I'm really glad to be here, because one of the things I really regretted not having studied is law. So I'm very honored to be with many of you, since I've learned a lot from reading your work. But here I get to talk to the real lawyers, so I'm very pleased about that.
Yeah, and I would invite Vaughn to jump in here, because she's added some comments in the chat as well. Vaughn?
Thanks, Mara. For me, it's just about us asking different kinds of questions. We've been operating in a very specific paradigm in this industry for so long that I think we've forgotten how to imagine and think creatively. And so we need to bring that back. What is the equity impact should be a part of that conversation, but we have to intentionally insert that question. It's not currently built into the way we think about our problem solving, right? We have to intentionally insert the idea of if our value that we are adding is that we are eliminating disparities and that we are reducing inequity in our system, then we have to build those kinds of questions and conversations into our process for how we plan. But right now, there's not really a lot of mechanism for doing that because, as Harold said, the payment models haven't caught up to that yet. And a lot of the strategic that's taught in health policy school and in business school doesn't focus on any of that. So I think we just have to start asking some different kinds of questions and be willing to go there.
Yeah, and doesn't that require, won't that require a sea change in terms of the, because as we all know, the payment system right now is designed around a lot of different incentives, all labeled paying for outcomes, that our payment system right now has moved from paying for procedures to paying for what is done to a patient, for example, to now paying for outcomes. And so how does equity and health justice play into that, if at all, or does it require an entire system redesign?
I mean, for me, I think we have to talk about what we mean by outcomes. I think right now we have a very narrow definition of outcome in terms of what is the result of the procedure. So instead of paying for the procedure, we pay for the result of the procedure. But the outcome in terms of someone's whole health is much broader than the outcome of an individual procedure. So I think that, from a policy perspective, we get to have a very different conversation about what do we mean by outcomes? What are we even measuring? And I think that's again, it's about thinking a little bit more broadly instead of reacting to the way the current system doesn't work. Let's imagine something a little bit different, imagine something new, not throwing everything away, but let's get out of the paradigm of, well, we put Band-Aids on this. And so, instead of paying for the Band-Aid, let's pay for the scab that forms 6 weeks after the Band-Aid. Okay, well, we're still focused on the Band-Aid. Let's talk about what it means for them to not get cut in the first place.
I would just second that. I would just second that. I think as was mentioned in the chat too, right? We want to talk about what value here is. So I don't think the problem is a conceptual one with focusing on outcomes. As you've just said, the question is, well, what are the outcomes? If it's reductions in access to healthcare across groups defined by a meaningful notion of social vulnerability, that is an outcome you can measure in very concrete ways and can be integrated. So I really think it's a matter of aligning this process that's underway and making it more focused, more attuned to avoiding inequitable outcomes. And I think the paradigm itself doesn't stand in the way. It's just that we need to be intentional about it and have attention to detail, really.
So going back to our overarching topic for this particular session, are there ways in which institutional decisions perpetuate racism, bias, and lack of equity in healthcare? I mean, we're all talking about sort of on the how to fix it, how to improve it, how to change way. But what are some examples of decisions and decision-making other than those that we heard from Rakia with respect to workforce? Are there other decisions in the healthcare equations that perpetuate racism, that perpetuate bias? With respect to the delivery of care, Melanie?
So I'm going to answer, I'm going to be a typical lawyer. I'm going to answer your question, but maybe not answer fully the call of the question, because there was another point I wanted to make that's tied to that. I represent a different part of, I think, an important player in the continuum of care, and that's the pharma industry. And I think one of the ways in which we have acknowledged as a company that we had been playing into the racial bias is that historically for our clinical trials, we were going to the same players time and time again because we had relationships with those individuals, with those institutions, and we did not have a broad reach into communities of color where, in order for us to truly meet our ambitious goal of, delivering healthcare options for all patients, then we have to study healthcare in all patients. And we weren't doing that because we were going to a very narrow segment of, the healthcare population. And so I think that was one way we were inserting bias in a way, is because we didn't really know how effective some of our drugs for breast cancer, for example, were efficacious in Black women, which we know the disproportionate number of Black women, die due to breast cancer. And so one of the ways in which we course corrected, and I'm so excited to hear some of the speakers talk today, was around being vulnerable as a company to realize we don't have all the answers. And so we started to engage with community leaders across the United States who are addressing, how to advance inclusive research, and how to address the biases in research, and also tapping into the local communities to understand how do we increase participation by Black and Latinx patients? How do we engage with physicians in these communities? And if there is a knowledge gap in terms of how to participate in clinical research, then how do we help close that knowledge gap? And so really moving from a paternalistic point of view to a more, I'll say still some paternalism there, we have a ways to go, but we are working on that to a more leaning in with curiosity and learning from the communities themselves in terms of how do we better reach, how do we expand our scope, and then also in creating new KPIs for our clinical trial teams. They were incentivized by going fast. And then now we're saying, how inclusive are our clinical trials? How inclusive are our protocols? Are our protocols automatically designed to exclude certain ethnic groups because we might automatically, have higher, percentages of different things that might be part of the exclusion criteria, and really trying to take a whole multidisciplinary approach to increasing inclusion in our clinical trials. So from, the incentives internally as well as the outreach externally. So I just wanted to add that perspective, because I think the pharma med device industries are important players in increasing, increasing equity in the continuum of care. So.
And Melanie, if we could stay with you for just a minute, I'd like to ask if and thank you for contributing your company's process in self-examination, I think is what was required. But what about the rest of your industry? Is this also a dawning happening across the pharma industry?
It is. I think it's slowly but surely happening. I think more and more companies realize that, it's an imperative, and that as an industry that we definitely have to address our practices. So, you start to see more, there's a trade association called Pharma, and they've brought different members of industry together to talk about what is our stance on inclusive research? How do we address health equity, not just in our research practices, but also in our other business practices? So that's another area where you're starting to see others in the pharma industry and med device industry come together. I think COVID also highlighted why it's imperative for us as an industry. But I think we have such a long way to go, right? I think this is the first step in the right direction. Our CEO and other CEOs are starting to make very vocal, active commitments, and not just talking the talk, but walking the walk, to really increase the impact that we can have in addressing equity in the healthcare field.
Thank you. I really appreciate that. Thank you, Melanie. And Ed, you've got an active and quite connected and long set of questions in the chat. So I'm going to invite you to come forward and share.
Yes. Well, thank you. I've been
Sure.
appreciating this conversation. I was a state health officer for 7 years and really looked at all of the social issues, and we, in trying to build in equity in everything we did, we set up a theory of change about around community organizing the narrative, organizing the resources, and organizing the people. And we decided in each of those areas, we had to ask specific questions on every single policy and every decision that we made. And so what I put in the chats were the questions that we asked with every policy decision, every programmatic decision that was made. Who's benefiting? Who is left out? What worldview do you bring? Do you bring that whole worldview of an individual responsibility, or community perspective? Do you bring it from a white perspective or a more diverse and inclusive perspective? And so those were the questions that we put, and it really actually changed how we did our work at the State Health Department, and it is having impact throughout our state in Minnesota.
Great, thank you. And again, in the chat, I believe, critically important suggestion by Vaughn about the fact that maybe we think about changing medical education. Do you want to talk a little bit more about that?
Yeah, this is something, because I did a lot of work when I was in practice with GME, I got to see what the criteria were for professional competence, and they never thought about or talked about equity and sort of what it means to treat patients from an equity perspective. And the more I look into this and the more I do research around it, you think about how are we even taught what constitutes professional practice? How are med students taught, how to engage with patients and how to interact with communities? And to a great degree, they aren't taught that, right? There's a bias and sort of a racist perspective built into a lot of the curriculum that has never been challenged, right? And we're at a point now where I think we need to challenge those things, because I cannot expect someone to do better if we haven't taught them any better. And so when we think about what are some of the ways that we as institutions, if we are running training programs, if we are, delivering medical education, have those equity questions that Ed put in here. Are those a part of the way we design our instruction and our curriculum? Have we even considered how those things impact? And if we haven't, we really need to get on that if we want to have the kinds of significant impact on shifting the way healthcare is done.
Great. Cindy, do you have a hand up? I'm seeing your hand up. Is that for time?
No, not for time.
Okay.
I had a question that I wanted to ask Melanie and others. We've all heard and seen, the historical hesitancy and concern that many diverse communities share because of, sadly, horrifying things that were done to them in the past. We all know about what happened at the Tuskegee Institute. So how would you all suggest ways to break through that concern and that hesitancy and help those communities recognize that, not in a paternalistic manner, because I think that's probably the worst thing we can do, to say, oh, don't worry, everything's fine, we're treating everybody well now, but how do you really break through that and try to get the diverse community to recognize it is okay to participate in a clinical trial? I will be treated just like everyone else who's participating in it. I actually have a client that's got a multi-site, clinical trial organization that was very involved in the COVID vaccine trials, and was working hard to try to bring in more of the diverse community into their database of patients. Because as you said, Melanie, they kept going back to the same places all the time, and they want to try to expand that. Thank you.
I'll start, but I don't know that we have the perfect solution. I think it's about, we're operating at a significant deficit of trust still to this day. I think, from participating in clinical trials all the way just the relationships that they have with their healthcare providers in and of itself. It kind of goes back to the point Vaughn was raising, that there is still this bias that healthcare providers have, and it impacts their relationships with their patients. And then the removal of institutions from communities so that they no longer are able to build relationships with their providers. They only have these urgent care centers, or, now they're only seeing doctors through the ER. Like, that's just completely eroded, the old concept of having a relationship with your family physician. That being said, I think one of the ways that we are trying to overcome this hurdle is by the relationships that we're building with community leaders. So it's kind of one leader at a time, one community at a time, and trying to establish that trust, and talking more about the benefits and the value of diverse participation in our clinical research, and leveraging those thought leaders and those who know the community and know what will go well. I guess what information the communities will receive better is the best way we found to be effective and impactful. And then by storytelling, by having people who've participated in those clinical trials and their positive experiences on those journeys, I think has also been impactful for us as an organization. But I think those are just, continuing to engage. I mean, I cannot emphasize how much we have come to learn and really value the importance of community engagement at all different levels. And it's one relationship built at a time.
I would like to add to that because, when the pandemic started, certain agencies, we were meeting NIH and all these folks, and they're like, what do we do? How do we, how do we get people enrolled in trials? And I was, they're looking at the Native and Black community, and we're like, we ain't got nothing for you here. And they're like, but we need the data. We need it now. We need to figure out how the vaccine. Okay, but what they say, what I said was like, it's too late. If you're trying to build a relationship right now during a pandemic, it's too late. You should have built these relationships a long time ago. And so, yeah, it is going to be too late. And if they do want to have better trials, it does take a true systemic commitment, I believe, to really engage the community. Because, I mean, I grew up in the Black community. I represent the Native community. Both of those communities are telling me, I don't care what you're saying, Francis, I'm not taking the vaccine. And so I think a lot of it has to do with trust and building it over time, and not just when, they wanted trials. Because I think that's, for my community anyway, that's how it looks like. Oh, now you want me engaged in trials? Yeah, I'm not going to take that. And Tuskegee came up a lot for that. They used to, sterilize Native women in the IHS system, the same system that we're working in today, is how they were sterilized. So some community is like, some folks are like, no, I'm not doing anything with the trial, and I think that's going to take, I think, a lot of time to dismantle the lack of trust that our communities, rightly so, have with these systems. So I think, yeah, community engagement is key. And it's still, even with that, it's going to be hard, I think.
Well, thank you, Francis. And on that note, we are getting close to our time, and I think we're about a minute out. So I would ask if anyone has a last comment for this very interesting session. Great. Well, with that, I will turn it over, and I'll turn it back to Cindy and the next person.
Great, thank you. So the next panel that we have is going to be the equity in COVID vaccine distribution. And so I'd like to welcome everybody to that. I will briefly introduce the panelists and then turn it over to Drew. Let me apologize already for mispronouncing anybody's name, and feel free if you mispronounce mine, it's fine. My name is Rakaya Yerby. I am a professor at St. Louis University School of Law, Center for the Health Law Studies. Our panelists today will be Dr. Dana Bowen Matthew, the Dean of the George Washington University School of Law. We have Professor James Hodge, who is the Peter Kiewit Foundation Professor of Law at the Sandra Day O'Connor College of Law, Arizona State University. We have Dr. Harold Schmidt, who was previously introduced. We have also Dr. Andreas Gonzalez, who was previously introduced, and Francis Convener. I know I said that wrong, so I apologize. And I am going to turn it over to Drew, who's going to introduce himself and then open up the discussion.
Thank you, Rakaya. I'm Drew Bhattacharya. It's nice to be with you, everyone. I'm the Vice President of Diversity, Equity, and Inclusion at Advocate Aurora Health. And let's hit the ground running here. So our topic today is focused on equity and COVID vaccine distribution, and we've broken it down into 8 subtopics, which allows us about 5 or 6 minutes for each one. And Professor Yerby and I will take turns facilitating that discussion. And so we'll begin on the topic of vaccine prioritization. So Professor Schmidt, we know that there are geographic disparities in risk and access to vaccines. And we've seen how some hospitals and health systems have used zip codes to prioritize patients. Others have adopted the social vulnerability index. Others have also integrated what's known as the area deprivation index. So is something better than nothing? Is it more acceptable to adopt one criterion over the others? And so thank you in advance for your participation.
Sure. Yeah, and so just to orient everybody briefly what these indices are, just in case that's not your bread and butter, they're basically different compound measures that try to give you a numeric score for capturing how disadvantaged or not people living in a particular area are. And the ones that were mentioned now are the sort of main players. I think that's exactly right. We have the sort of scholarly version, which is the area deprivation index, integrates around 17 different variables, is very structured in the sense that you can't pick and choose individual elements. The score that you compute is done in a very mathematical way. The social vulnerability index was developed by the CDC for disaster preparedness, not at all for something like COVID. So for hurricanes and floods and things like that, is, however, the most widely adopted one. And then there's a whole range of other ones that have been set out. California developed its own index. And I think to your initial point, that would indeed be my response here, that one is better than none. With colleagues, we're in the process of doing a systematic review, understanding the way these indices are constructed and how they conceptualize disadvantage. But the really important thing to understand is that for basically until last year, the way we thought about equity in vaccine allocation was through the priority sequence of groups, right? Everybody knows, oh, who gets it first? That was what everybody got upset about for the last half year. But the important thing that disadvantage indices tells us is that the equity story doesn't end when we allocate vaccines to the entire population in a few weeks, right? Next week, in fact. Within each of the groups, people are at different levels of disadvantage. Within older people who are, of course, at more disadvantage than younger people, some people can easily socially distance if they're well off and live in the suburbs. Other people who live in crowded inner city settings cannot. So that's the point that the National Academies really recognized in saying, within each phase, we have to recognize that people differ in their levels of disadvantage. And simultaneously, this is important for public health and equity, such that we prioritize people who are worse off in vaccine access. And that can be done in a number of ways that I think we'll also still talk about.
We appreciate that. One of the things that necessarily flows from the guidance, whether at the federal or state level, is that there's no clear algorithm. So many of the considerations that are put forth are just that. They are considerations. So mindful of that and against that backdrop, Professor Hodge, some states have actually encouraged consideration of protected classes. And considering that, what are the practical implications of that kind of geographic prioritization with or independent of those other protected classes for either organizations or the communities they serve?
Yeah, Drew, great question. Listen, back several months ago, when I had the chance working with the National Academies to review the vaccine allocation plan before it went out, Harold's seen it and many others on this call, is I alerted them, to exactly what Harold was talking about with the distribution. I said, listen, from an equity perspective, a lot of what you're suggesting in this specific plan looks on target, and it's solidly backed by good scientific approaches to what we knew about COVID spread and other arenas. But I told them, in regards to that, I said to the committee, don't expect politicians to follow. So what or how you're going to actually attempt to follow these specific equitable recommendations across the United States with different geographic issues, geographic political priorities, and otherwise, I knew was going to be a major challenge. You're seeing exactly that in the sort of first 6 to 8 months of implementation of the vaccines themselves. Drew, your question really raises a great point for us all to consider, and that is in a federalist structure of which states get to call the shots largely about who's in line, when, and under what circumstances, how much tolerance should we have for specific set-asides for groups, acknowledging that states won't all follow the same script. They clearly haven't with regards to COVID-19 vaccine. And most importantly, you cannot trip up on the sort of issues that get you into court on equal protection or due process or other specific fronts as well. The moment you do that, you're delaying actual vaccination implementation in a way that can only be deleterious as well. Those are the tripping points we've been watching all along, and to be sure, they continue, even as you know, we're about ready to launch into a sort of national program to make sure everybody has some access. These issues aren't going anywhere for sure.
Great,
Can I add one quick point there?
Please, Harold.
So this is a really remarkable thing in the way this has played out. As we just heard, it was national academies that recommended to adopt this in a broad way. But formally, it's a CDC committee, the Advisory Committee on Immunization Practice, that provides guidance to states who were, let's just say, not so hot on this. And they simply didn't really embrace it to a full extent. But the states went with us, right? In a situation where they have a lot on their plate, we now have a majority of states use a disadvantage index one way or the other. Colleagues and I did a couple of reviews of that. And it evidently means something for them. So that's what's really remarkable, that within all the other variations that we've seen, this is something they weren't asked to do, they didn't have to do, and they still saw immediate value in it. And I think it is precisely because of this recognition that we had last year, that if we continue allocating vaccines in ways that maximizes benefits, we're not going to reduce inequities, we're going to maintain them or worse, exacerbate them. And I think that's the potential that is really remarkable that we're seeing there.
Harold's point's excellent. To be sure, some states have followed the script pretty closely, even without having to. In other words, the Fed's saying you don't get vaccines unless you follow this script. So obviously the Feds have not done that and probably will never. However, some states have gone way off script too, flatly saying we're not sending this to prisons first. We're not going in that priority order. We're not making sure that we set aside 10% of the allocations for persons to actually gain access for equitable purposes on racial or other specific lines. Listen, those have been tripping points legally. I'd love to hear from the Dean as well as to her thoughts.
Thank you so much, Dean Matthew. Let's rope you in there. So as you know, it's not just about disparities, which we're all familiar about in healthcare, but it's about the unjust disparity, and where you live matters. And so mindful of that is race and place so inextricably intertwined that they necessarily, considering both, overcomes those concerns about prioritizing communities. Thank you for joining us.
Thank you very much for asking me. I want to jump in and do two things. One, I'm going to defend the honor of the ACIP, the Advisory Committee on Immunization Practices. I was on that committee, and I do want to give a little bit of insight as to what we thought about race, specifically race in place and race in this vaccine. And then I want to be just a little bit provocative, if I may, and talk about what Vermont has done specifically to identify race as a criteria for prioritization. So first, with respect to the ACIP, you're right. We weren't as operationalized as you at the National Academies were. It was admirable. There's nothing that either James or Harold has said that I would disagree with. I would say that there is in the ACIP effort a much more focused, broadly addressed justice focus than was on those operationalized definitions that the National Academies were looking at. In other words, we were concerned not just with lists of prioritizations, but those larger issues of injustice by race and by class. And so we focused on questions of not only injustice, but inequality, unfairness, and the kinds of conceptual problems that would go beyond this vaccination. Very much to your point, Harold, that we don't solve the problem simply by prioritizing people, because race and place continues to matter with respect to the distribution of comorbidities. The morbidity and mortality inequalities were a reflection of fundamental inequalities in housing, food security, employment, every one of the social determinants of health. And so we were talking about injustice much more broadly than respect to prioritizing a list with respect to the vaccines. Let me turn to, and I think because I only have a minute, I'm going to use a provocative phrase. When we look at vaccine distribution today, we see white supremacy in action. We see a problem of morbidity and mortality that is disproportionately affecting communities of color, and we see the solution listed in priorities that disadvantage communities of color. If you look at the 66% of people who have already received this vaccine, it is white people, right? White people are the only group that have a higher level of vaccination than they have cases, deaths, hospitalizations. People of color, African Americans, indigenous populations, Asians, all of us have a lower level of vaccination than we have an incidence or prevalence of the disease. That is white supremacy all over again. And so simply listing the occupations or simply listing the prioritization doesn't get to the bottom of the issue, I dare say. We had better be doing more with respect to structural racism than just telling people what occupation, what age, and where they have to go if they're on a list for priority. This is a bigger problem than that.
Thank you so much, Dean Matthew. And I think that this really piggybacks on the last discussion very well, because trust really begins with transparency, and that transparency means honesty, integrity across the board with all the indicators and how they relate, and not just singling out some at the preference of others. And so I appreciate your insight. And so we're turning now, focusing on the race-based allocation of COVID belief and ethical decision-making. I'll turn it to Rakaya to continue that discussion.
Yes, so let's go into the discussion building off of that, and maybe coming back to you, Dean Matthew, just about this race-based allocation. I actually would like to talk about how we begin to address legally how we can attain equity.
I think we're going to need some more radical and forthright, dramatic cooperation and collaboration between law, medicine, and health. We cannot leave just to the people who are activists on the streets to ask for Black Lives to Matter. We cannot leave to those of us who are doing civil rights law to advocate for the ACA Section 1557 to be enforced. We need people who are in healthcare. I loved the earlier panel where Ms. Mills was talking about the pharmaceutical industry and the medical device industry. We need the conversation about race inequality to be enlarged so that it doesn't just include theoretical discussion with academics, young people marching in the streets, or those of us who are writing articles inside of the academy. We need people like the people on this call to begin to care, not just about the tip of the iceberg, but about the very fundamental structures of racism that are affecting health outcomes. How would that look? Well, Vermont has shown one of the ways that it would look. They have pushed the envelope and said the trope that says we are allowed to identify race and ethnicity when we are disadvantaging populations, but not allowed to identify race and ethnicity when we are advantaging populations is unacceptable. I don't care who's on the Supreme Court. I don't care who's been appointed to the Fourth Circuit. If the people on this call would say that we were perfectly happy during 1937, when we were redlining districts, to say that they were infiltrated by foreign-born, they were infiltrated by racial minorities, and that needs to be reversed because those are empirically connected to health outcomes. Why? Because education is determined by place matters. Food access, access to clean air to breathe and water to drink. If those connections were made, then we could begin to convince the Supreme Court and lawmakers that they are wrong with respect to whether we can or cannot mention race and ethnicity specifically when we talk about vaccine distribution. We've been too passive, we've been too accepting, and we've been too siloed. We've thought this aggressive address of racial discrimination belongs to one and not the other one of our industries. It's all of our problem. I'll close by saying this: structural racism kills everybody. So if you think about interest convergence, just to borrow from Derek Bell, right? We have plenty of data that tell us that death from myocardial infarction or infant mortality rates increase for Blacks and whites, where there is explicit racism measured higher in one county than another county. If it's not because this is the right thing to do, if it's not because inequity is distributed along racial lines in every one of the social determinants of health that we swing into action, then do it out of self-preservation. Racism kills everyone, and structural racism is something all of us need to get much more serious and much more aggressive about addressing.
Thank you. I will turn the question over to Dr. Gonzalez.
It's a great point that Dean Matthew just made. And I will tell you, being very transparent here in our discussion, that we made that faux pas here in Milwaukee. When we started actually looking at the allocation of our vaccines in the greater Milwaukee area, and I'm sure many of you remember, over a year ago, Milwaukee was actually on the center stage because we had the highest percentage of Black males who were losing the battle, who were actually dying. And as they were coming through the doors, through our systems, some of us were doing a better job than others in terms of understanding the issues, right, and providing equitable care, right? So if we were committed to that, right, it actually meant that then we're providing more services to those individuals and populations, right, based on their symptomology and the realities of those patients and communities. And yet that was not actually how we actually approached it. And so for our own system, as we actually looked at even advocating for the vaccines, actually our enterprise chief medical officer tells the story that we actually were fighting for that. We were able to get allocations for some of our most vulnerable communities, right, our BIPOC communities. And yet when we opened the portals, primarily through the electronic medical records, who was actually benefiting from that? It was primarily whites, right? Because we did not understand the digital divide, right? Some of the issues that some of our communities, vulnerable communities, actually were experiencing. And so it actually then showed us not only that reality, but then what were we going to do, right, in terms of that call to action? So we took the stance of then setting aside vaccines, and then running vaccine clinics very targeted for our BIPOC communities. And so we had to engage our community at large, some of our community partners, and it was actually through them that we're able to actually make some inroads, whether it was the federally qualified health centers or some of the community-based organizations. And actually, I have to give a shout out to Drew, because Drew and I actually are the co-chairs for one of the regional efforts here in Milwaukee, which is the Milwaukee Healthcare Partnership that brings healthcare systems and the federally qualified health centers together in tandem to really address not only COVID-19, but any issue related to health or healthcare in our community. Very unique model here. And he and I know, because we have heard from our own federally qualified health centers, where they actually, and it pains us to hear that even their fight for getting their staff vaccinated when they were actually in the frying pan was actually an uphill battle. And so it actually took Advocate Aurora, Drew's system, and my system and other systems to come alongside and say, listen, yeah, we would certainly be privileged, right, and honor if you would send those vaccines to our health systems, right, and for us to vaccinate our healthcare workers. But what about those folks who are the frontline folks who are, right, day in and day out fighting this, who are actually exposing themselves at a much higher level and rates to get actually contracting that virus? And so it really took advocacy locally, regionally, at the state level to make that happen. And so certainly it was actually one of those mistakes that we made. It was actually a great lesson learned for us, but certainly a great opportunity moving forward that we have built as a lesson learned for us not to repeat moving forward. One more point that I want to make, because I think it has been critical for us as well, because it's actually related to equity, diversity, inclusion. One of the things that I have learned that has been so critical for us and profound is having representation of our communities at the board level. Board governance is key. And that is actually something that I want to stress in terms of the importance, one of the key strategies that I think is going to become important for us. And so in our own system, having BIPOC leaders who are sitting at that level, right, who are being obviously unapologetic about keeping that agenda item for our CEO to have to report it, right, and to have to be transparent and accountable to, has become critical and probably the game changer for us. So I bring that up because honestly, one of our board members said to me recently and said, Andres, if we would not build this as a standing agenda item, then we're going to actually, unfortunately, this will be diluted. We're going to move on to something else, something probably as critical as vaccine, right, which is probably the civil rights issue of our era, and yet we would be shying away from commitments and issues that we need to actually address and be accountable and be and have authentic conversations and certainly have transparency around. And so I think that has been a key for us here at Freighter. And I know that I talked to a number of other colleagues nationally, and everyone has, I think, repeated the same thing, that having that board governance in place has spoken volumes, especially in this particular pandemic.
Thank you, Andres. And let me follow to your point as a question to Dean Matthew, and I'll also welcome Professor Yerby as we talk about this in the context of addressing the distrust and the mistrust in our communities, because it is a fact, as Dean Matthew, you've said, that there is a disparate impact in what has happened, not only the disproportionate burden on the front end, disproportionate access on the back end as we've rolled out the vaccine. Absent that kind of heightened self-accountability that to certain systems or hospitals, what can we do to scale up those kinds of models? What can we do to actually overcome those barriers as they exist, so we can kind of get ourselves on that pathway, as you've alluded to make this culture shift, as it were, absent that legal mandate?
So I'll get started. I think there are others on the call that have more to say about this, but let me continue in the vein of being the provocateur here. First of all, we can stop the myth of vaccine hesitancy. It's not true. People of color want to live just like white people want to live. People from indigenous communities, people from African American communities, people from Latinx communities are not thinking about Tuskegee in order to figure out whether they will or will not get a vaccine. They're thinking about what's happening today in healthcare that is not crediting their views, that is not respecting them as humans, that is not creating structures that protect their health. So you don't have to look back at the Tuskegee. We need to fix today's trust relationships, number one. Number two, the Pew Foundation did a study about 2 weeks ago and reported that just like whites, Blacks, about 61% of them are wanting to look for this vaccine. So this myth of vaccine hesitancy has much more to do with access, has much more to do with transportation, has much more to do with whether community health workers are actually sending out the messages to community members in ways that they can trust and relate to. It has much more to do with the location of hubs and the distribution of information online or not online, right? Southeast DC, which is right down the street from me, bred for the cities, has vaccine distribution. There are more white people online down there. They have never made it down to Ward 7 and 8 in previous settings, but they're down there now taking up vaccine. Why? Because they're on the internet and they're able to sit and do the refresh regularly, right? So these are the structural issues that really do matter with respect to what we can do. And let me make no mistake about it. None of this is a surprise. We saw with H1N1 that uptake by race was severely disparate. It is unethical and immoral that we weren't ready then and we aren't ready now to intentionally address racial disparities with respect to uptake. And telling ourselves the myth of vaccine hesitancy is one of the biggest problems and barriers that I think we need to fix.
And I'll jump in just to add on to that, right? That it also is about what we are providing for people to do to get the vaccine. We are not providing for paid time off to get the vaccine, and right, even the option once you get the vaccine, if you need to take time off. Right. I recently got the vaccine. I was out for 2 days and that was just the first shot. Right. And I have the privilege to be able to do that. Many of our essential workers don't. And what is really sad about that is many of our essential workers working with and for healthcare institutions do not. Right. So if you're wondering why a traveling nurse or a nurse direct care worker who's providing care in a nursing home or somebody's home doesn't want to get the shot, is because they can't afford to take off work, right? You may be giving out the shots to the people in the nursing home, but you are not ensuring that they could take off time if they need to actually deal with the symptoms of it. And so the hesitancy is really about what has happened, and not just in how people have been denied care, how they have been blamed for these inequities and infections and deaths based on what Black culture or Latinx culture, that is somehow their fault. And now all of a sudden you want them to rush to get the vaccine, where you're not even ensuring that they're going to have what they need to be able to get it, which is time off and paid sick leave. So I would add to that. I see Harold's hand up, but Francis, I wanted Francis Mills or Francis, I wanted to give you the opportunity also to speak in about these topics as well.
Well, Rakai, I'll jump in and say for the city of Cleveland, one of the challenges is that you do hear that terminology, vaccine hesitancy, being bandied around as a challenge. We are seeing in our African American community and Latino communities that numbers are down, but it's a matter of how well has information regarding availability been communicated to folks on the ground, but also utilizing traditional media, radio media, media in language that people can understand. And so to date, from December, we've probably set up probably over 100 pods in the community and have really distributed all of what's been allocated to us. Now, do we have those sites where aggressive outreach and community engagement needs to happen? Absolutely. How we're doing it through partnerships with nonprofits, partnerships with faith-based community, partnership with grassroots activists, partnerships. We're letting people tell us where to go when we're making that decision, because where are new cases happening? In a place like Cleveland, what good is social vulnerability index when everybody's socially vulnerable? And so we could go anywhere, but we have to go to places and hold those pods where it's convenient for individuals to come. So that's the way we're handling it. It's a daily challenge. We're more likely to take all who comes, whoever wants it. We want to make sure that it's there. And then we want to apply aggressive education for those who, in the event they might be hesitant. And people will tell you why they're not interested or at this time, or we would like to delay our scheduling of our appointment. They'll tell you that, but not shutting the door and making it difficult for people as they are ready to come in the door and get the vaccine.
And I could add to that so one of our facilities in Spokane, they vaccinated the whole Native community, and they were like, what else are we going to do? And so they went to NAACP, they went to local Asian organizations and started vaccinating those folks. And I do think prioritizing is a little, it is essential, or has been essential, or figuring out how that works. I did want to talk a little bit about the digital divide. We have with COVID, we've seen that, I mean, obviously with telehealth and everything, I think a lot of folks have, we've all had to move really quick to get comfortable online, but we did see that a lot of our patients didn't have access to internet, or did not have a smartphone or a laptop, and could not access those telehealth services that they may need, that may be hit during. And so we know that, I mean, we're talking about infrastructure a lot these days in DC. We know that Indian Health Service is severely underfunded. We know that tribes are severely underfunded. And so the access to internet broadband is just a huge, huge, huge problem. Now, my organization represents the urban component of that, which has a lot of problems there. One being that the legislature does not think that Indians live off reservations. They think all of us live on reservations, when 70% of us live in urban settings. And so So a lot of the resources that are considered for our community are only considered for reservation based because they think that we all still live there. And so that just becomes a communications challenge even to get the resources to folks as well, to make sure that the feds are accounting for and thinking about the 70% of us in urban settings who still have, we were at some point collecting old cell phones to try to give to people so at least they had a phone that they could call. And that became a policy issue at the very beginning when they were just like, oh, telehealth, but not telephone. And so there's a lot of investment I think that needs to be done in infrastructure to help bridge that access. And we've seen some things happen, but I'm happy to see that, I guess, the infrastructure package that they're trying to tackle things like this now, because it's an H1N1. Urban Indians at least were completely forgotten about. The whole system did not even account for the urban Indians. And so we were one of the highest to die in that pandemic as well. And so, the numbers are always going to be the same as long as we are trying to respond to inequity versus implement equity in our systems. I think that's kind of one of the challenges I'm really seeing.
Francis, thank you so much for that observation on the digital divide. And just a couple observations from my end. This is exactly what we saw unfold in our own system. When we did that pivot and we started to do more live outbound calling, we saw the vaccination uptake go from something as low as 20% in some pockets to 100% of the, just because folks would pick up the phone and just make the calls as opposed to relying on email, other things. Another point that was seeing in the chat, the great point that Francis Mills has raised is looking at call-ins, walk-up opportunities for access. This is exceptionally important in certain communities. When earlier they'd introduced me as overseeing a lot of our community-based flu initiatives, what we noticed is that of the 55 clinics that we had set up last fall in the communities, the ones that had, they were all walk-ups, all free of charge, but we were also other social needs at the time. And so the one clinic that also had voter registration as part of that kind of package of service, the highest uptake of all the clinics. So it was recognizing that the needs that we are prioritizing aren't always the needs the community might be prioritizing. We need to look at this in the context of what communities want at a given time as well. And so having that community focus, community view at the table, I'll give you a chance to chime in there, but also Ruqayyah, just hand it back over to you as we transition to the next subtopic.
Great. I want to turn it over to Harold. I know you wanted to speak on this, and then I'm going to follow up with a question about crisis standards of care.
And sorry, is this, when you said speak about this, was that the trust point? Because I think I'm just going to do, this got me all through middle school, that I always wait until the smart kids have spoken, and then I would say, that's just what I wanted to say. You said it so much better. So I'm not going to say more on that. But happy to talk about crisis center of care if you'd like to.
Yes,
okay.
Yes. Tell
Sure.
me more about that.
So I think in many ways there is a very direct relationship, but also a very interesting difference. The direct relationship that in my world in bioethics, we've really seen, I would call it a seismic shift, that pretty much a year ago, the received wisdom was, well, absolute scarcity, so we maximize benefits. Not everybody can have everything, that's the way it goes. And I think within less than a year, we've just come to this realization that if we do that for ventilators or other things, what that means is we'll either maintain or worse exacerbate inequities that we see, right? And so we've really seen this switch around in quite a way, that the need to mitigate this inequitable outcomes has been recognized within the field. So, again, to be fair, what happened a year ago was that many people were very concerned that if we have first come, first serve, that would be highly inequitable. We had some states that would exclude particular people from access to a ventilator, and that was bad. That was clearly, very bad. But the problem is that some of the guidance that had been set out in response also had issues. And so I initially wrote an op-ed in Times that I put in the chat in a moment, looking at one influential model guidance that drew on the SOFA score, which is a clinical measure to assess your likelihood of surviving the ICU, and considered life expectancy in ways that I felt would disadvantage, in particular, the chances of African-American people who were more disadvantaged to get a ventilator. Later, I followed it up with a piece with Amaka Nyanya, an outstanding nephrologist, and Dorothy Roberts, who many of you know as a legal scholar and a sociologist, of course. And we looked less at crisis center of care, but just at SOFA, and made 6 concrete recommendations what you should do. And the main problem is, and I put that early in the chat too, with the SOFA score and integrating creatinine, is that in measuring creatinine as an indicator of kidney function, we're measuring simultaneously social disadvantage and an objective clinical measure, right? Many clinicians will just say, well, we're just doing objective science here. But the fact is you are measuring disadvantage. And the question then is, well, what do you do about this? Because as we hypothesized initially in our paper, it can make the difference between being assigned the highest priority and not. And more recently, and I'll be sure to put that in the paper too, we have empirical evidence for this being true, where Dr. Shana and colleagues looked at a large study set of more than 100,000 patients and found that, and this is a site here, I think I have it up, yes, that in 81% of cases, Black patients included in lower priority crisis center of care categories, and in 9.4% of all Black patients were erroneously excluded from receiving the highest prioritization, right? So there's no question in my world and in the medical world now that using creatinine within the SOFA score has these harmful consequences, will from the start disadvantage worse off African-American people. But the question is, what do you do about it? And one interesting thing here is that much as we're rightly obsessed with vaccines, or focused, let's say, on vaccines, when I raised this initially last year, many of my colleagues would say, well, look, we're in the middle of a pandemic. Can you please, leave that for later? So, I thought, okay, that's interesting. Now we're luckily, and hopefully will stay that way, can avoid needing to think about rationing ventilators, but we can't leave things stand that way. And I'm heartened that the National COVID Plan did ask the Health Equity Task Force to provide federal guidance on standards of care, on crisis center of care. We made 6 suggestions for what you could do that I'm not going to work through, but I'll just give you the titles. That you can improve diversity in decision processes, you can adjust creatinine scores, you can drop the scores, you can find alternative measures, you can add equity weights. Again, that's how I first thought of using a disadvantage index, or you can reject the dominant SOFA model altogether. So this is 6 constructive elements that we feel you should at least think about. And doing nothing is not an option, right? We've established the fact that these protocols have inequitable outcomes. We can't hide behind objective science, and we need to figure out what we do as a society about it. But the bottom line, again, for me, is that we've made this recognition that simply maximizing benefits is no longer acceptable, and we now have to really learn something from this period and be clear about how we want to do this better.
And I'll just jump in and to say that now is the time, right? Because as we're looking at Michigan, as we're looking at the Midwest, we are ramping back up, unfortunately, to a lack of ventilators, lack of access to beds, right? And so it becomes a question that we have to handle now. I'll turn it over to you, Drew, unless somebody else wants to hop in.
Great. It seems that many of the obstacles that we're seeing are really part of a broader issue of justice. And Professor Hodge, kind of bring you back into this discussion here. We talk about justice because we know that the failure to justly allocate, whether it was ventilators in the front end or now vaccines in the back end, contribute to these higher rates of morbidity and mortality. And you noted back in 2004 that we've seen this before. This is not unprecedented. We saw this with the influenza outbreaks where high priority groups were not always vaccinated ahead of healthy individuals. So what have we learned from these prior missteps? What are your suggestions for going forward?
Let's be clear about a couple of things with COVID-19. It is unprecedented. It blows away everything else we've seen before. It's a totally different scale, and it will forever set for this century what we have and have not done well in response to allocating scarce resources. That what Harold's talking about with crisis standards of care, I've worked with the national academies on that. We have some new work to be done there. What Dana's talking about with some of these really just structural issues underlying it, COVID-19 blows all that off the roof. And it just does it because of the magnitude of what we're seeing. This is that big event. Drew, you're right. What we observed back in the past, we're seeing perpetuated to this day. And some of it, I dare say, we're going to resolve post-COVID. I think we actually have seen enough nationally to understand with leaders like Dana and Rakaya and Dawn and others, we've got a chance now to actually set a new scale going forward. But let's also be conscientious of a couple of things as we do so. First, ethics will get us so far in relation to what we should do or how we should respond, or what or how it could be a good thing to actually allocate like this. You got to make it stick legally. And we're going to see, I think, massive legal changes in response to how we respond or how we actually handle these types of pandemics or other issues going forward. That's what COVID-19 will actually address. We're talking about a very different national infrastructure for how we should proceed. There's going to be some changes from our federalist system and approach that may help remedy some of what Dana's just been so eloquent in talking about and Harold's addressed and so many others. But I think the one critical facet we've seen is that there has been a couple achievements. Let's not lose stock of. First of all, we're passing out COVID vaccine for free. We're handing this stuff out nationally. That's a good objective. We set that all along and it's been done. We have safe vaccines. That's another objective. Thank heavens these vaccines are safe. Throw a little in more in there about AstraZeneca's related issues in regards to that. Oh, it's just going to be more problematic than ever. What we've got to solve is the allocation conundrum. That's solvable. It's going to take a heavier approach at the federal level, I predict, for the long term. And we're going to need to see a lot more outlets extensively across the country able to dole out vaccines now they're going to be open wide to the US population. In other words, any access issues we've seen so far might be remedied if every Walgreens, every CVS, and every Walmart can actually do these vaccines in real time. Those can make critical differences. We've learned a lot, Drew, but the next part of this century is where we'll see it effectuated. That's, I think, where we're going, and law will be absolutely critical to that in reflecting the ethical balance as well.
Thank you so much. I think that that key point, meeting people where they are, physically, financially, across their own knowledge base, because as Dean Matthew pointed out, it's not just about it's not about these presumptions of hesitancy and that narrow way that has been portrayed, but also across that continuum of folks who have legitimate concerns. If I have so-and-so health condition, or if I have these access issues of transportation, please help address those, right? Rakaya, let me bring you back in here as we talk about equity and the law, and kind of lead it off with you as we wrap up.
Yeah, and I'm going to turn it over to Dean Matthew, who I know is going to give us the answers, or at least be provocative and telling us what we need to do.
Okay, so there's no way to live up to that, but I do have something that I'd like to close to say. First, thank you for having me on this panel. One of the reasons I was so excited to get this, the honor of having this invitation, was because of the audience. Not only the people in this panel, it's an honor to be here with this group of, I'm going to call you activists, because your intellectual work is activism. But the people from the American Health Law Association and those that listen are the answer, in my view. And let me just lay that out theoretically first, and then touch on it pragmatically. Everything that Harold and James and others have been talking about supports a theory called fundamental cause theory that Link and Phelan reported 1995. 2015, they identified structural racism as a fundamental cause of health disparities. Now, Rachel, the CDC recently said structural racism is a public health threat and crisis, but let me just break down what that means. From a theoretical standpoint, it means that if we attempt to address a crisis without deliberately, intentionally addressing the structural racism that envelops that crisis, we're going to see exactly what Harold described. The inequities are going to get worse. And this is not news. This is not news at all. We've seen it. The classic example is cigarette cessation, right? So when you put resources out without thinking about race, gender, economics, all you do is put those resources out into an inequitable system, and they get inequitably distributed. And so people who are disadvantaged are worse off after the solution has been found than they were before. So the only way to attack this, and I share James's optimism, the only way to attack this is to recognize that we are at a crossroads, at an inflection point. Either we take structural racism seriously and attack it intentionally, or we make it worse. And when I say intentionally, I mean the kind of bold moves that Vermont has made. I mean the kind of attacks on race and race discrimination, on white supremacy that Vermont and even West Virginia has made. The reason I love what West Virginia has done is because they looked across their rural communities and said, I'm going to use your word. I thought it was so beautiful, Francis. I said, ain't nobody coming to get this vaccine unless we do something deliberate. The only way we're going to get this vaccine out is to use community pharmacies that people already trust. And that's why West Virginia and Alaska have been so successful. The only way we're going to get rid of structural racism is if people in the health community make the empirical connection between inequality, racism, discrimination in housing, education, food, employment. You have to make that connection with health outcomes, because that's the way policy people are going to listen. That's the way lawmakers are going to listen. They are not going to listen just because the academy is saying that educational deficits produce health inequality. They are not going to listen only because communities are marching in the street. They're going to listen when you empirically show the connection that health outcomes are directly related to racism, to people not getting promoted, not getting jobs, not getting educational equality, not getting the right to breathe free and clear air. I come from the South Bronx. Asthma Alley. Why? Because the law permits waste transfer systems, highway systems. All of those are connected to health. And if you, the health industry, you health lawyers, you health providers, begin to become civil rights advocates to change the laws that are creating discrimination in each and every one of the social determinants of health intentionally, that's the only way we're going to beat this inequality. It will just continue to get worse otherwise, in my view.
Francis, did you want to add something?
Yes, thank you. Even though I can't follow her, and Dean Matthews, absolutely amazing. You are my new favorite person. I wanted to put a plug in here as we are thinking about diversity and being our own agents for change. One of the things that I went to the University of Arizona, James, so we're natural enemies. But one of the things I advocated when I was in law school was mandating critical race theory. And I definitely think that this is something, I mean, I'm talking to all the lawyers, so I want to just say that, like, if any, I think, and one of our things was that, I walked into a white law school. I thought it was going to be a whole bunch of Indians like me, and it was a whole bunch of white people. And I grew up in an all Black area. So I was like, where are all the minorities? And I grew up in South Florida. We had everybody. It was wonderful. And I was like, wait a minute, what's going on here? And what I learned was, we are part of this cog. We are part of this system. And if we don't acknowledge that race is a factor in this, then we've already lost. And I spoke, a few years later after law school, I spoke to George Zimmerman's attorney who presented at my undergrad. And I wanted to ask him about this. And he said that I had served Black men my entire life, and the system has always failed them. Always, always. And I was surprised to hear that from George Zimmerman's lawyer, however, but needless to say, and he did say that. He did say he thinks that as long as people are still pretending that things are colorblind, like you're never, and that case changed my life, because I saw how race, how if you don't talk about it, things can happen. And so I just want to put that plug for the deans here and any law students or future law students to push for critical race theory, because I think we have to, we can't just pretend that race doesn't matter in our own clients or any of these other things. So I just wanted to put that out there as well.
Francis, I can't speak for U of A down in Tucson, but I bet you every single law school represented on this call, from the deans to St. Louis to my own here at ASU, do have strong new affirmative initiatives towards that specific objective. Now, these cannot be flash in the pan initiatives. These need to be permanent fixtures. But to be sure, yeah, we're increasingly on board with it at ASU, and I bet every other law school as well.
I'm glad to hear that, because Arizona needs it.
And with that, I am going to close this session and maybe turn it over to you, Cindy. I know we are supposed to be taking a break before we pick up the next panel. All righty, it is 1:45 Eastern Time. And I think everybody is back. So why don't we get started with our panel on social and political determinants of health. As I mentioned, I'm Rakaya Yerby, a professor of law at St. Louis University. I will be moderating this panel with Dawn Hunter, who is Deputy Director at the Network for Public Health Law. We have Dean and Dr. Dana Bowen Matthew here, who is the Dean of the George Washington Law School. We have Jay Nadine Garcia, who is Executive Vice President and Chief Operating Officer at the Trust for America's Health. We have Samantha Bent Weber, who is a program analyst with the Centers for Disease Control and Prevention's Public Health Law Program. We have Professor Scott Burris, who is Professor of Law and Director of the Center for Public Health Law Research at Temple University Beasley School of Law. We have Edward Ellinger, who is Acting Chair at HHS's Secretary's Advisory Committee on Infant Mortality, and Sarah DeGaia, who is Chief Executive Officer at Change Lab. And again, I apologize if I mispronounced anyone's name, please correct me. And with that, I'm going to turn it over to Dawn Hunter.
Hi, everyone, and thanks so far for a great discussion. And I think you'll find that we're about to enter a panel that will combine some of the elements of each of the previous panels. We have a really nice transition from this last panel in particular, where we heard about some of the barriers to vaccine equity that are also more broadly barriers to health equity. And as we developed the vision for this panel, we had a lot of ideas, but they generally centered on the role of law and policy in shaping the social and political determinants of health via three kind of key areas: institutional practices, training and workforce, investments and spending to improve health equity, and data collection, policies and practices. So these are the ideas that we had, but we want to start out by asking you, from your perspective, what even are the social and political determinants of health? And what is the most important issue in this topic area that the audience should know about? And who wants to kick us off? I know Dean Matthew was really touching on this at the end of the last panel, and it might be nice to lead off there.
Okay, I'm happy to start off also because I'm going to duck out of this panel a little bit earlier, but I'm looking around the room and I know a lot of people on this panel have a lot better handle on this than I do. So I'm going to take the 35,000 foot level and continue my role as provocateur. One of the things that I know that Scott and Nadine and others are going to drill down on is the empirical connection between law and health outcomes. I want to talk a little bit more theoretically about a miss that we have not paid a lot of attention to. And I hope Sarah DeGaia will back me up on this because I know that the Change Lab Solutions has been very active on this. And that is the use of civil rights law to address health disparities in every single one of the social determinants of health, right? So anybody who's very serious about health disparities should also be very serious about voter suppression right now. So if we are seriously interested in changing the fact that communities of color live in more polluted places, so they breathe dirtier air and drink dirtier water. If we are seriously concerned about the income gap that not only is the result of residential segregation, but is also the result of educational segregation that persists throughout the United States, thereby underpreparing people to compete in the labor market. And we do see the connection between those civil rights disparities and the very plain disparities in morbidity and mortality that we are seeing, not only in the outcomes with respect to COVID-19, but in the solutions with respect to COVID-19. Right? As I said on the earlier panel, and I just have to say it again in case there's a different audience here, white people are the only people who have more vaccine prevalence than they have death, disease, and cases. African Americans die more, get hospitalized more, get diagnosed more with COVID-19 than they get vaccine. Same with indigenous populations. Same with Asian populations. Same with Latino populations. The only people who are getting more vaccine than they're dying are white people. That is white supremacy. And it is no surprise to those of us that have been doing disparity work for 10, 15, 20 years. So although it is true the COVID-19 pandemic blows all other use cases out of the water, this is unusual, extraordinary, exceptional. There is nothing new under the sun here. And unless we get serious about racial discrimination in each of the social determinants of health, we are not serious about health disparities.
Well, thank you for queuing us up on voter suppression in particular. We're going to talk a little bit about civic engagement in the next panel. But maybe I can ask Sarah to comment on the piece that you comment on what we're missing, which is the use of civil rights law to fight discrimination in all of these areas that you've been mentioning. Sarah, do you want to chime in here?
Sure, and thank you, Dean Matthew, for queuing me up here. And a lot of the comments that you said earlier, I think, are just absolutely right on. So I just want to underscore what you've been saying, and also allude to something that Francis mentioned earlier around critical race theory. I think that, you know, as lawyers, as health, working in the healthcare field, as advocates, we tend to kind of think within our own silos. And I think what COVID has really lifted up is that we can no longer think in these silos. We really need to take that extra step in terms of working together and really understanding and leveraging each other's strengths. So we did publish a paper that just came out in UCLA Law Review this past year, where we look at the things that we can learn, the strengths that we can learn from the social movements that are happening, Black Lives Matter, the Me Too movement, really understanding that place of power and the role that community needs to play within helping us understand decision-making and actually helping to participate in decision-making, helping to lead decision-making. And then in the public health perspective, using that data. The data is not the ends, right? We don't just stop with the data. We need to actually utilize the data to help drive where do we identify where the resources and the investments need to go. So the answer is not in the data. The data is a tool in order for us to understand what needs to change. But I think we get so caught up in like, we got to have more data. No, it doesn't end there. But we need to really embrace and understand what public health has been doing for a long time, which is looking at that population data and really understanding it, but going deeper and looking at it from disaggregating that data and really understanding the depths and the breadth within that information. And then the last piece is, this is where the lawyers, I think, really come into play, and where we do bring a strength into this conversation, which is the important role that laws and policies play in either reinforcing systemic racism or as a means to address systemic racism. So the legacies of segregation have not been erased and have not actually been addressed, because all we do is continue to look forward. But as we mentioned earlier, we need to actually look backwards. We need to understand the impacts that segregation, that racism has played, that exclusion, that slavery has played within our society, to then be able to understand how do we redress and how do we move forward. So Rakaya, Professor Yarby, you mentioned truth and reconciliation. We need to have those discussions. We need to make space for that. And I do think that cities and counties declaring racism as a public health crisis actually opens the door for us to have those conversations. But again, that's the first step in order to then identify what do we need to do next. So really understanding the role that civil rights can play. What are the tools? And also recognizing that a lot of those tools have been blunted over the years. Dean Matthew, I know your book, for example, really lays out a really nice framework for understanding how do we actually strengthen those civil rights tools over time. So I think we are on the precipice. We have a lot of leaders who are acknowledging race, who are acknowledging disparities and inequities in our society. And I do really think that this is the moment to take what tools we have and to really move the conversation forward.
Sarah, all excellent points. I'm going to pull out one thing that you said in particular, which is using data to drive resources and investments. And I'm going to ask Scott to join us in on this part of the discussion right here.
Well, thanks. Although I think you guys have inspired me. Let's put it that way. So many comments and so many brilliant points throughout this evening that I've been listening to, and it's sort of driven me away from my usual point, which is we need to study the effects of laws on health. We need to, if we had been properly studying the effects of laws on health, it wouldn't have taken 50 years to find out that the Fair Housing Act didn't put much of a dent in segregation. We would stop looking to fake solutions and depending on them for so long. We might have realized earlier the depredations of the war on drugs. Controlled Substances Act was passed in 1973. And it's 30 years before we get the new Jim Crow. But I can't resist taking a bigger answer to this whole set of questions that you've posed, because I too am a big fan of Kamara Jones and was reflecting on her allegory of the garden. The idea that she had these two garden plots, one that she nurtured with new soil and fertilizer and watered carefully, got these beautiful flowers, and another which just had old soil, never been cared for, actually probably been the dumping ground for junk and chemicals, and it barely supported any healthy growth. And her point was, you can't, flowers grow in the soil. If you want healthy flowering, you got to have healthy soil. And until we really look at that soil, the underlying social conditions, we're not going to have healthy growth that's equitable across all parts of our population. So for me, the fundamental imperative that is actually sort of happening now a little bit, in which we cannot lose, is to make long-term substantial changes to the policies that drive inequities, and that could, if they were reformed, maybe turn around some of the inequities and disparities. We are in a society now that has, for the last 40 years, done everything possible to make rich people richer, and has successfully created the greatest inequality and the lowest social mobility in our country in a century. And in keeping with the old physical law that high water is always worse for those on the lowest ground, this general inequality has been disparately hard on people of color, and particularly people whose family trees in America are rooted in enslavement and generations of consistently hostile de jure racism. And I think this is an important point. I think critical legal studies in law school is a great topic. We all ought to have it. We don't all have it. But even more than that, we need legal history. My students come to law school with this kind of vague notion that Lincoln and the Civil War freed the slaves. And there were a couple of bad moments in there, Plessy v. Ferguson and all, but then Thurgood Marshall came along, the Supreme Court, got rid of segregation and racism, and everything's been great since then, mostly. They have no idea. They have never been taught about the consistent and unrelenting use of law to subordinate Black people in America. That has gone on without cease to this day from the Civil War. So, obviously, one of the first things we have to do is just stop doing racist things to Black people through the law across the board, as many commentators have already spoken about. But I think every policy reform discussion that we have also has to lead us back to three deeper questions that we need to ask about every policy. Are social resources being devoted to investments that create and security and opportunity for most people in this country, not the 1%, not the top 10 or 20%, but the vast majority of people who are, not doing so well in this country of all races. And then secondly, doing that, taking up Dean Matthews' point, are we ensuring that racial disparities are being redressed and not perpetuated in these reforms? Because we could easily fix a lot of things for some people and make things worse for other people, as Dean Matthews said. And finally, are enough resources being collected to make the necessary changes? We are talking about serious redistribution of wealth in this country. So if we are not talking about major tax reform, both in individual and corporate tax and inheritance taxes and so on, if we're not talking about huge investments in housing and education, to get rid of homelessness, to get rid of substandard housing, to get rid of poor education. If we are not talking about taking this germ of a guaranteed basic income that we saw in COVID and making that a basic entitlement for all Americans, then I don't think we're serious. I don't think we're going to succeed, because we cannot bring social justice for anybody, as is said, without substantial economic justice for everybody.
Scott, that's difficult to follow. Great, your points are great there. And I want to ask Ed or Nadine if you want to jump in here and talk about, what this looks like on the ground and in terms of targeting resources to impact population health.
Yeah, Don, let me jump in. It's nice to be on this panel of great legal minds, and I don't have a great legal mind. I'm a physician who's been in practice and working in public health field. But Don, I want to get back to your original question to this group: is what are the social determinants of health? And I also want to, I'm glad I'm following up Dean Matthew, because I want to highlight the fact that she said so eloquently that if we're not focusing on equity and particularly structural racism, it's public health malpractice. I mean, it is central to what we're doing. It's public health malpractice if we don't focus on that. And what I really like about the whole issue of social determinants of health is that most people in the general community think that if you just made good personal choices about diet and physical activity and exercise and had good medical care, you'd be healthy. That's the common mantra. That's the worldview. And we know increasingly that it's really where the conditions where you live and work and go to school and worship that really impacts your health. And those are the things in those communities that impact your health are beyond your individual control. They are social control. That's where it gets away from this whole idea of the individual being responsible. And, you know, I certainly think individuals need to take some responsibility, but the big issues are really social. And so social determinants of health are the things that impact your health that are beyond your individual control. And those things are really structured based on policies and systems and environments that have been put together over the years that have been based on a structurally biased, racist perspective. And for us, you know, and I always argue, you know, I'm always asked, you know, why is an old white guy talking about equity? Because we're all in this together. And I think those of us, and it really struck me when I was a state commissioner of health back in 2014, as a privileged heterosexual male physician, white physician, to say that structural racism was the centerpiece of the problems that we're having in Minnesota related to disparities made a big difference. It opened up the conversation for folks, and the communities of color said, thank you for identifying what we've known all along. And now we're going to hold you accountable for making some differences. And this is where, you know, we need to get communities engaged, and we need to have the communities hold public officials accountable. And then this gets at the voting things, which we're going to talk about on the next session.
Well, thanks, Don, for opening us up, and just to build on what everyone has shared. It's really been great to listen to all of these panels today. You know, where Ed just left off with regards to talking about the social determinants of health, and I come at it as well from a public health and health equity lens and perspective, is understanding too and not conflating the issue of social determinants and equity, because all of us, right, experience the social determinants of health with regards to the conditions in which we're born and live and worship, et cetera. But that there are those wider set of forces that actually shape those conditions. And that was something that others have mentioned with regards to issues like who holds power in communities to be able to make those decisions. And that then brings us to, Dawn, what you earlier asked about the political determinants of health. And I'm sure many of you, if you have not have read Daniel Dawes's book on the political determinants of health, and where he structures and talks about the elements of voting, of government, and policy as being those three key elements within the political determinants of health. And so it ties to those social determinants of health, because we all experience them, but what we're seeing, and certainly the COVID-19 pandemic has shined a bright light. We in the health equity movement knew that these inequities existed, but shine a bright light and have also exacerbated those inequities. And we see them not only in health outcomes, but certainly in the social and economic conditions. And we then consider, how did those conditions come to being? And you think about then really those levers and those dimensions of voting, of government, and thinking about government structure, policies that have been perpetuated over generations, not only at the federal level, but also at the state and local level. And then consider as well the policies themselves, and looking at how you examine, so an entity like government that can examine, should a policy actually be dismantled because it is having inequitable outcomes on populations? Should there be a new policy that is created? Or should policies be continued? And so I think there is this intersection between the two. And I appreciated the point, the National Academies of of Science, Engineering, and Medicine had a report in 2017 that affirmed that point. We hear this often when we're speaking to policymakers or others about this. It's individual choice, or it's randomly occurring, and understanding that these health inequities and these health injustices that we're seeing, they're not the result of individual choice and a random occurrence, that these are generations of inequitable structures and systems and policies and norms that have been accepted that are perpetuating these inequities and are now having a collective impact that are certainly disproportionately impacting communities of color.
So to follow on that, I want to go back to actually ask Melanie, because you were talking a little bit about this from an institutional perspective, to build on what we were just hearing Nadine say about what it looks like to then address the social determinants of health in the institutional setting that you're in.
Sure. So I am a public health professional first, but now I'm a lawyer and I'm practicing in a pharmaceutical biotech company who has publicly made, their commitment to addressing disparities in care and racial inequity in healthcare. And I think one of the ways in which we have made our commitment firm is acknowledging that the social determinants of healthcare they do impact, people of color. And one area in particular we focus a lot on is childhood trauma. And we have committed over $20 million just in the last year to efforts to really address the impact of childhood trauma on children of color, in particular, who are disproportionately impacted by trauma, and how that has an impact on their overall health outcomes. And so I think taking steps like that is an important first step in addressing, the health equity or health inequities in our community. And I guess more broadly, I think, as we're talking about the role of academics, the role of government agencies, something that Dean Matthews said that I really appreciate is that this, the way that we're tackling these issues really is a multidisciplinary approach and does really require the input and effort of various entities, including the pharmaceutical and biotech and medical device communities. I think they're often kind of looked to sometimes as a source of some of these areas or some of these issues. But I think that there is a role that attorneys like myself have too, in holding our leadership accountable to putting their money where their mouth is, to putting their money where their commitments are. And so the ways in which they've supported something like childhood trauma, or the ways in which we leverage our PACs to support laws that might have a disproportionate impact on communities of color, and really leveraging my seat at the table to speak up and talk about the impact of you supporting certain tax incentives that might benefit you as a company, but are going to have a significant, serious impact on the health and well-being of our Black communities. And so there's lots of ways in which I think we can leverage our voices as lawyers too, sitting at the table, not just through laws, but also speaking up to our leadership about the impact of things that they're supporting and its adverse impact on our communities.
Well, I'm going to ask Sam to jump in here and share your perspective too. How are we leveraging our voices to address some of these social conditions, and what does that mean, social conditions versus social determinants in a healthcare setting and in a public health setting?
Thank you very much for allowing me to participate on the panel. It's been a really robust and enriching conversation over the last many hours, and I've really enjoyed it. I just want to go back. I'm sorry, Don, I may not totally answer your question.
Totally fine.
But I want to go back to this idea of defining the determinants of health. And, one of the things I've been thinking about a lot is, do we need that language? Do we need the language around social and political determinants of health? Whose imagination does that capture? Does that really help ordinary people who are not in public health practice, people who are not lawyers, to sort of fully grasp the idea that social conditions, where you live, the experience you have, the access to tools and resources of power, does that get you better health? Does that language sort of help people to sort of internalize the idea and then think about how they can help to move the needle around social conditions and improve health? It's something that I grapple with a lot, because I think to your point about sort of moving the needle on this issue, part of the story here that I think is one that people within health and public health practice need to engage with, but also lawyers who have a tremendous number of tools in our toolkit around engagement with people, is that, we have to figure out the communication story, right? Like, how do you tell the story about the ways that laws have harmed people in a way that's accessible? You know, to Scott's point about sort of what law students don't know when they come into law school. That's a problem that exists across all disciplines, across the entire population, right? We just don't have an historical sense, but we also don't have a sense of what it means when people talk about inequities or inequality or poor conditions and populations that get disproportionately harmed. We don't really know how to trace, right? Federal laws, local laws, state laws, we haven't figured out how to sort of trace the way that the legal infrastructure has directly and acutely impacted people's conditions and lives, like the decisions they make, the resources they have, the places they go, their sense of their opportunities. And to me, that is a big part of the story of capture, of like moving the needle on structural racism and moving the needle on the discourse around determinants of health and advancing health equity. So I started by saying, do we really need to talk about determinants of health? But one thing I want to say is, you know, the point that I think we need to figure out a way to be able to articulate for people, all people, including people within the legal discipline itself, is that law is a concrete determinant of health, right? Lots of us talk about this, you know, who work in the public health law space talk about this. You know, Sarah and Scott have written about this a lot. But in terms of like articulating it in among the broader public, among people within public health and outside of public health practice, that law determines health and law drives health, right? I think we've got to we have to look inward, is what I'm saying. We have to look inward and think about ways that we can interrogate the way that we think about and do public health law practice, but more broadly, the way that we think about and do legal practice, right? Like how does public health thinking also inform the way that we practice as lawyers and think about the law and interpret the law and help policymakers and communities think about and engage with the law. And I think, you know, it's such a sort of 35,000 foot point I'm making, but it's actually really practical and concrete in so many ways, particularly because everyone here is, you know, engaging with students, engaging with the public, engaging with policymakers, engaging with people in private industry. And, you know, I think that is a conversation, an ongoing and robust conversation that we need to have and continue to have every day, all the time, about how we talk about this stuff and how we begin to articulate, you know, change making, right? How we trace the nexus between law and health, and then what we do with that, right? So I'm going to stop there.
Sam, you're speaking my language here. Everything that you're saying, you know, just is really spot on. I was thinking, actually, one of the things I wanted to pose to the panel is really, you know, how do we talk about social determinants of health when we know that's a term that is a huge turnoff for some policymakers and some, you know, right? How do we talk about the impact of laws, you know, all the evidence that exists about the positive impacts of Medicaid expansion, and we still have states that are holding out and states that are trying to overturn ballot initiatives, right? The impact of minimum wage increases on people of color. Despite the evidence of the success of all these laws, we still have people saying, yeah, I don't really think that's a thing. So, you know, I want to pose that to other panelists. How do you suggest, you know, what are your suggestions for how we talk about this and how we approach this with people who maybe are just not quite there, but could get there?
Dawn, that's been one of the blessings, the side blessings of the COVID epidemic and the racial violence that has spun off of here in my hometown, the murder of George Floyd. All of a sudden, people are recognizing that there is a large population in our society that is not is not part of the conversation, and that it's the economic policies, the social policies, the educational policies, the legal framework, who's at the legislature. It's all coming together, and it's really tangible because they're feeling it in their community. They're feeling it by how safe it is walking down the street. They're feeling it by who's dying in their neighborhood. So this is the opportunity that we have to then craft our stories around the crisis that's going on right now about racial violence, or still disobedience and racial injustice protests, and COVID. This is an opportunity. So that's where we're trying to bring the stories around those two episodes.
I really think it's as basic as it's about power. It's about power and opportunity. And I think there's a notion that laws and policies really can help to either emphasize who has the power or who doesn't have power and opportunity. And I think if we're talking about how do we talk to community, it really is about how do we make sure that people feel that they have their own power, that they have a sense of agency, that they can actually participate in the process. And part of that to me is about sort of demystifying what the law and policy practices are. But it's also about making sure that government is accountable and that they do have policies and that they have an engagement practice that is actually really welcoming, and that where people feel like they can meaningfully participate in making those decisions that are going to have an ultimate effect on themselves. And I think right now we do need to do the analysis and understanding, and there is a way to do that. There are practical ways of understanding and analyzing laws and policies to understand who will benefit from these laws and policies and who will not benefit. And those are things that we need to make sure that cities and counties and state and the federal government have as they are bringing down the big dollars, right, from building up local infrastructure, or as they're thinking about rolling out racial equity initiatives. And then also really thinking about the role of preemption, for example, and taking away that power or authority that locals may have versus states and federal governments. And the last point I wanted to make was just in terms of really having, I think it's important for our government levels to understand that they work best when they are in coordination with each other. And when they are not in coordination with each other, then that's when who is most affected is going to be community members. Government is their role is to protect people's rights. There is no other entity who is going to protect our rights other than government. And so we need to have them understand that role and that responsibility. And we need them to be at the table and really and having much better coordination and communication so that then community does feel empowered and is a part of that process.
I would also throw in time and a little bit of self-care or patience with ourselves on the communications issue. I mean, it's easy to feel like you're not getting the message across whatever language you use because change seems so slow and painful compared to the need for change and for the possibilities of change. We have to keep in mind that the people who taught America to believe that who taught a bunch of Americans who loved FDR and were delighted with the New Deal, that the government is the enemy, and that the best they can do for you is keep its hands off your Medicaid. They spent 30 years and billions of organized dollars telling that story again and again and again. When Barry Goldwater ran for president in 1964 and was trounced by Lyndon Johnson, people thought the idea that his attack on government was absurd. Nobody was into that. But the people who supported him just kept saying the same thing until Reagan came along, until you had enough repetition. So, I think I absolutely agree with Sam that we don't need to talk about social determinants most of the time. Oftentimes, we just have to talk about the terrible things that are happening, because that really gets people know that, and they feel bad about that, and they want change. If we have systems of policing that involve finding people into poverty, finding people into jail, burdening people with crushing court debt, we can talk about that on that level. As such, it's just cruel to take people of $1,000 in their whole life and charge them $1,200 for a traffic ticket. But I also think that we have to have a positive, inspiring vision. That's how systems change. Systems ultimately change with the big picture. And we have the best picture there is. There is nothing better than an equitable society where everybody is respected, where everybody has an equal opportunity and has a chance and can make a good life. And there are lots of people who don't feel we have that now. And we have the opportunity to offer that in contrast to people who think we should have a winner-take-all society where, a few people win and the rest of us, well, we're losers. We should be able to sell that.
And I think there are elements, excuse me, Scott, I think there are elements too of really knowing and understanding the audience to whom you are speaking. And what might drive change. And I agree with the point that some things are going to be able to move more quickly than others, or some points are going to be able to move more quickly than others, but knowing what drives change and knowing how we communicate that, whether that's through stories and narratives, whether that's through data, and how we present data also with a framework that actually promotes racial equity and doesn't stigmatize communities. As well as looking at, in many cases, making that economic and business case, especially in the case for policymakers, where sometimes that feels like it's the antithesis of what we would want to do because we're trying to come at this from a humanistic perspective, but understanding that there are going to be these different ways in which we can explain these issues and understanding and tailoring to the audience, and then taking an opportunity where there is some type of a social movement or something that may be expected or unexpected. We can talk about the racial violence that we have seen and what the nation is currently experiencing, but racial violence certainly has existed for generations. But when we see this type of a movement now, how can we actually use this to lead to transformative change? And I think that, and to do so, I really appreciate it as well in a way that's interdisciplinary, because this is not something that public health can do alone or healthcare can do alone, or in the legal profession. We have to come together across these various sectors, public and private, as well as other sectors such as education and criminal justice, to see this as a holistic approach to really transforming and creating healthier and resilient communities.
This is a dynamic discussion. I just want to point out really quickly, we're going to have Heather and then we're going to have Sam, and then I'm going to turn it over to Rakaya for any closing kind of comment or question. All right, Heather, take it away.
Thank you. And I'm going to try to not repeat the ideas that I think that I've heard from lots of my colleagues. And I'm going to go back to kind of something I said earlier about the role of other disciplines. And I think Professor Garcia, you may have just mentioned this as well, or Dr. Garcia, I apologize, not knowing which. But I think the idea that we really need to, particularly as lawyers, we often are asked to come in as the experts or the one to explain everything to other people. And I think it's really important for us to be, and this goes to what someone put up about the role of grace, daring to fail. I really think we need to be willing to listen to both people who are going to ultimately be the most impacted by some of the policies, and not simply later, but having people at the table. Again, I'm gonna be a broken record, driving and helping to lead the conversation or leading the conversation. And I think Sam made a good point earlier about whether or not we really know what we mean when we say community. How do we define that? And I think that's the conversation that Sam Weber brought up that really needs to be had as well. But also other professionals. We're talking about messaging. Are we engaging with communication specialists or people who do political messaging? And maybe we are, but where we aren't, should we be? I said at the beginning, I do social work. Social workers often are working directly in communities. And if asked, could tell you who they see as leading voices, and then going to the community and asking them if they see the same thing is important as well. And acknowledging social work sometimes can function as an arm of the state as well in a negative way. So really considering all of those things, but thinking about those professions that are already doing some of the work that we as lawyers who are trying to craft policy could have taken off our plates as we do our work. And I think, Scott Burris, I mentioned this earlier, but that transdisciplinary public health law really, I think, does a nice job of touching on each of those issues that we all could from our own perspective take and think about what that would look like. So I know we're short on time, but I just really wanted to make sure that again, the community piece and Sam's wise admonition to think about what we mean when we say that, and the transdisciplinary component, I think could really enhance what we're already working towards in public health law and policy.
Just to sort of perhaps repeat myself, but also to piggyback on some of the other comments, I do agree with what others have said about this being a rich opportunity for us to not only think about how we can make change and move forward, but also step back, right, and remember what we're doing, right, and why, where health fits in the larger story about how our society is structured and operates and functions. How do we centralize health in the larger story about who we want to be as Americans, what it means to live in the society and to engage with the society and the government and the system and structure we have. And I think we're in a difficult, complicated, contestable, but also rich time of potential and opportunity. And so I'm trying to focus on being optimistic around that too. And I hope that we can center the sense of possibility as we think about how we look at our disciplines, right, within the context of health and public health, but also other disciplines. My sister's a transit planner, and we talk constantly about transportation, and how there's this tremendous overlap in the way that, and some of the challenges we see in our respective disciplines, and how we can do more to advance equity. So I'll stop there.
All right, so I want to thank everybody for this conversation. One of the things I want to add in the closing, which hopefully you will get to as we talk about civic engagement, is that when we think about the structural, social, and political determinants of health, that when we talk about race, that we also have to connect people's other identities, which at this time are also coming to play, particularly in states deciding to pass laws to prevent access to care for LGBTQ and trans individuals. That when we think about racism, right, it is not just one individual, it is a part of individuals' identities, including their sexual orientation, their gender identity, age, disability status. So as we think about these issues and laws and how they have played out, we have to think about how it's impacted all of these marginalized groups, particularly at the intersection. So with that, I want to turn it over to Dawn. I know you're going to start us on our next panel, and I want to thank all of the panelists who participated in that panel. Thanks.
Yes, thank you to everyone for such a rich discussion. I wish we could talk about this all day, frankly. But we are going to start to roll into our next panel on our last very short, but I promise you, very dynamic conversation on civic engagement. Joining us are Sarah DeGia, Ed Ellinger, and Heather Walter McCabe, and anyone else who's on the panel who wants to contribute to this discussion. And I'm just going to kick us off by saying, we've heard throughout the day about communities leading and being at the table. We had high levels of engagement and voter turnout in the general election. We saw healthcare organizations, physicians, nurses, et cetera, promoting voter registration as a way to help shape health policy more broadly. And so I want to start off this last panel by asking, why is civic and community engagement so essential to addressing racial health disparities? And actually, Ed, I'm going to ask you to start us off.
All right. So I work in the field of maternal and child health, and I argue that the greatest public health achievements of the 20th century was the 19th Amendment and the Voting Rights Act of 1965. Because from when half of the population women got the right to vote in 1920, the maternal mortality rate dropped nearly 100%. And the programs that got started in state health departments focusing on women and children actually came to fruition. Infant mortality also dropped tremendously when women got the right to vote. They had an impact. And the next time when we really had a real decrease in infant mortality and maternal mortality was after the Voting Rights Act was passed. There's a huge impact of just having people's voices heard that has direct impact on health outcomes. We also know that this whole sense of belonging, a sense of feeling part of a community, is a big determinant of health. And one of the ways, it all relates around to the whole idea of social cohesion, and having your voice recognized and being that you have a way to share your voice with your community gives you a sense of belonging. And that's what really makes health grow in a community. And if you don't have that sense of belonging, you're not as healthy. We just see that where people who are engaged, particularly like people who filled out the census, the communities that filled out the census are healthier than the people who didn't fill out the census, because they had a sense of belonging, they had a sense of connection. So civic engagement is crucial. It is one of the biggest public health indicators that we have.
Heather or Sarah, do you want to jump in on that? I will say really quickly, I appreciate every time I hear you talk about the Voting Rights Act, and there's a lot of research about 60s era civil rights legislation, also significantly reducing infant mortality rates during that same time period. And it was so significant. And the next time we see a big drop like that is with Obamacare and Medicaid expansion. And yet, at the same time, infant mortality rates are still unacceptable for Black, Latino, and American Indian infants, right? And so somebody might say, well, we had all this progress, why is it still a problem? And that's something I want to pose to y'all. We have progress, but why do we need to keep working on this, and why do we need to stay engaged?
Sarah, did you want to go, or do you want me to? Okay, I don't know that I have a lot to add without being a complete broken record from what I was earlier, though I do want to specifically mention, following Professor Yarby's conversation earlier, not to forget about the role of stigma, which is either made better or exacerbated by policy. A lot of my work is done in the pardon me, dogs joining me, the LGBTQ spaces, and particularly a lot in folks who are transgender and anywhere within that community. And I think that it's really important to note how some of the dynamics that we're seeing impact multiple different communities right now are really playing out for the transgender communities. And thinking about the direct health impacts with the anti-trans bills, making it so that a youth cannot get the medically appropriate care recommended by WPATH and others, that's very direct. But also even looking at the athletic bills or other bills, formerly the bathroom bills that now don't exist, but continue to be brought forth in 16 states or so a year. What just even having these bills introduced, let alone passed, which is happening this year, can be doing to a whole group of people and all the people who love them. And so I think that I use that as an example, not that they're alone, but they're pretty visibly getting hit this year. But for all of these spaces, thinking about not simply the specific tangible health impact, but the impact of just living with these kinds of bills or policies, or just discrimination that may not still be in policy, but that's still taking place, can have on persons. And the mental health impact that we see in all LGBTQ communities is pretty substantial and should give us pause. And I know that community is not an alone. It's just a community where I have a lot of my work. So stigma is something to also consider as we're thinking about policy.
Yeah, just to build, I agree with Heather and Ed, and just to add on that, I think there's obviously a disconnect between who our policymakers are and who our communities are often, right? And particularly those communities who have faced decades and centuries of disinvestment, disenfranchisement. The system was set up for a particular group to benefit, and we have just continued to see that perpetuate generation after generation. So I think it's important to note that, like, right off the bat, is that, you know, there's a policy is sort of protecting its status quo in some ways. And I think we had been making some amazing strides. We've been seeing at the local level, in particular, people of color being elected to sit on school boards, and then making their way up to local councils, and making their way up like through the state legislatures, you know, and then we started to see these attacks on through redistricting, through voter suppression laws, right? And so it's all connected. And I think I don't necessarily think that people every day sort of see how these systems connect to each other, but I know that they're feeling the effects, right? I think there's again, this sort of bias that if you're a policymaker, or if you're a lawyer, if you're a doctor, that you are an expert. Let's agree, like, you've gone to school, you know, we all have degrees, but that doesn't necessarily make us an expert in all the particular areas or in all the ways that, you know, people have been affecting lives. Community members themselves are also experts. And I think there's this sort of notion that, like, well, they're not really speaking about in a professional or in a particular way. And that we really need to get over that. And I think we need to really embrace community as the experts within their communities. They know the walking paths, they know the childcare centers, they know the schools, they know the challenges as well as the potential solutions. And so I think our role could actually be leveraged as being maybe the translators for some of those, you know, how do we look at and really listen to community and then help to broker or negotiate or understand, and how to translate that into policy. And I also think that we need to kind of invest in capacity building also for local and state policymakers to understand how to facilitate meetings, how to engage with community, how to make sure that they can really sit and listen and hear and understand what's happening. And I think more and more there are frameworks and tools to help each other talk, just like across different sectors. So Sam, talking to your sister who's in transportation, we speak different languages across different sectors. We need translators across different sectors. We also sometimes need translators as we're listening to community. So I think there are some opportunities there. And I think we just really need to embrace community as experts and really make room for them at the table to help us in planning policies.
Dawn, you had mentioned, you know, the war on poverty back in the 60s, and what that was a health in all policies approach with community at the focus. It was really about community building. It was shifting power to the communities, and actually it got undermined because the communities got too powerful, and so the conservative right wing kind of undercut it. But we have an opportunity right now. I mean, and that occurred in the 60s because of the people that they put into power through voting. We have the same opportunity now. We're seeing with the Rescue Act investment in communities like we've not seen in a long time, and a huge amount of money. So this is our opportunity to actually have an impact similar to what happened in the 60s when we actually did reduce poverty, we reduced civic engagement, reduced health disparities. It didn't persist. And I have to mention the fact that when we shifted from investing in communities to investing in medical care in the 80s, that's when our disparities started to increase. It's almost as if the more money we put into medical care, the worse our health gets and the worse our disparities get. So we really have to continue to focus back on the community.
I really appreciate that. You know, we heard Andres talk earlier about community conversations, and I was in a meeting recently where somebody said, well, we want the community to have conversations. Who should do that? And I said, well, the community should. And he said, yeah, but who should lead it? And I said, the community members. And he said, well, who will train them? And I said, you're going to. It's your job is to equip the community leaders and the community experts to have these conversations. You know, your job is to help support the experts in the community in that process. So, you know, with that in mind, I want to ask you, for the audience, what's one kind of takeaway for how we can help support and promote community leadership on community identified needs and issues?
I'll jump in just because I also have to jump off in just a few minutes, but community engagement is not just about checking a box. It really, you need to have a thoughtful process, and we need to understand what are the outcomes. You can't just go to community with an agenda. You have to build the agenda with the community. And so that community, going back to what is community, I think if you can start with like local leaders, right? Folks who are influencers, members of churches, or members of local community-based organizations, local service providers. Those are all, many of those individuals are actually community leaders, and can help you kind of start to translate that information. But it's really essential and important to think about the process. To have a space where people can engage in multiple different ways, because some people aren't comfortable engaging in a Zoom conversation like this. So we have to have different types of ways. Language, translation, and interpretation services are really, really important, not just for individuals who don't speak English as their first language, but also for those who are maybe hearing impaired or visual impaired. So just really being as sort of inclusive, right? Thinking about the most sort of vulnerable person who is not going to be comfortable in all spaces. How do we plan a process that is going to allow for their voices to be heard in as equally important way as ours are here today? And then really important, that crafting of the agenda, because the crafting of the agenda will help people sort of see what are the parameters that we're talking about today. What is the process to engage? And then where issues come up that you can't address in a 5-hour meeting or even in a 1 or 2 hour meeting, is having a place where those issues can go to for the next meeting and the next conversation. And the last thing I would say is follow up. You can't just let the conversation end. You have to go back and continue to engage in that conversation, because that is a way to build trust and to build relationship over time. It's not going to happen overnight. It is a journey. And so we have to be invested in one meeting. Not all the problems are going to be solved, not even in 2 or 3. It's going to take years. It's going to take time. And you really have to build those relationships and that trust over time. So those are just a couple of examples, I think, if people really want to engage and have a meaningful process to engage community.
And I talk a lot about it in interprofessional education, how we can't just throw people in a room together and expect them to be able to do the work, that there's actually some skill to that. And I think that one of the things, building on what Sarah just said, is we may need to recognize that we have some work to do on learning the skills needed to do these kind of meetings. And there are folks out there, social work, not all of them, but the social workers who do community organizing or who've been in the community, they have a lot of those skills. There are other professions, public health workers or community health workers who've been in the field for years. They also may have those skills. And so recognizing that we then need to be willing to learn some new skills if we're going to do this kind of work. And oftentimes it's not the community who needs to learn the skills, it's us. I would purport, others may disagree with me, or maybe it's both, I don't know. But I do think that it's something that's really important for us to bring to the table, is we may need to come open to learning ways of doing this. Even things like, when do you have your meeting? Well, if you're used to having it 8 to 5 Monday through Friday and people are doing shift work, good luck, because they may lose their job or they may not be able to feed their family this week if they come to your meeting. So there's just lots of things to learn in this. And I'm excited to see people continuing to talk about it and hope that we do that work.
Yeah, and very briefly, I think we need to change the narrative about voting. We really need to recognize that voting is not just for politicians, it's not just for people engaged in politics, not just for the rich, not just for the white, not just for the urban. It's everybody's responsibility, and that it has an impact on the lives of people. So we change the narrative about what creates health, what creates thriving communities, and change the narrative about who votes. It's everybody's responsibility.
That's an excellent way to end this particular session. Great discussion. And thank you, Sarah, Heather, and Ed, for engaging in this conversation with me. And I have the honor of transitioning us into our very last question of the day. And I want to start by saying thank you to everyone for being here for the whole day, for participating in the various panels. It really has been just such a rich discussion. And I think, what I want to pose is a question that I think all the audience will want to know, which is, how do we turn all of this into action? How does an organization go from declaring an anti-racism policy to making an impact? And this is open to everyone who's been participating throughout the day, any order you want to go in. I'm actually going to throw it to Sarah first, because I know she has to leave us. I want to make sure that she has a chance to talk. And then the rest of the group, please be thinking about your response to how do we turn today's thoughts and ideas into action?
Thanks, Dawn, and thanks to the American Health Law Association for having this discussion today. I think to begin to answer your question, because I will say, I think it's going to be different for every community. And I think that there are a couple of immediate steps that folks can take. I think one, it's just really assessing where are you on this journey? What is your relationship with community? What is your understanding of what the local needs are? Have you done your equity assessment and analysis? Do you know the history of discrimination or racism or other policies within your local community that could have contributed to what is happening today? So doing that doing that homework, understanding, really getting to know the community, I think is a first step. And from there, being able to build on, do you have a health and all policies task force within your local community? Are your sectors starting to talk together? Or do you need to kind of create a glossary or common definition of terms so that you can start to begin each other's language? And then from there, I think really assessing, do we have a positive rights framework or do we have a negative rights framework, right? Are we thinking about how do we make education? How do we make civic engagement? How do we make healthcare available to all? Or are we thinking these are only, certain policies that apply to certain populations? So kind of thinking about that mindset and shift, and going back to the conversation around narrative. I think understanding what is the narrative within your community or your state, and what is the work that we need to do in order to get there. But I think there are already assets. Every community has positive assets. What are those positive assets that you can start and leverage in order to build on understanding where you are in your journey? And then how do you really identify sort of what are those next steps for you and your community in order to understand. And I will just say on the last point, again, going back to what is the data and what are your laws and policies, and how do you really center those laws and policies that are going to help you either dismantle some of those systems that are in place, or that can help you get to a place of creating more opportunities for all in your community.
Thank you, Sarah. A lot to unpack there. And again, kind of tying together the themes we've heard today about how we really interact with, engage, uplift community voices. Who wants to go next? This is open discussion here. What's one recommendation that you would have leaving here for how we can turn ideas into action?
I've always asked the question, what's the one thing to do? Well, there's everything needs to be done. So what's the opportunity that you have? What's the opportunity? You're all in leadership positions. You have a bully pulpit of some sort. How are you using that bully pulpit? How are you getting the message out to change the narrative? And who are you inviting in? Who are you forming partnerships with? Again, I think it's also public health malpractice if that everything we do is not building community capacity. And so how are you using your bully pulpit? What message are you giving? And how are you building partnerships that'll actually build community capacity, build power in community?
I'll hop in here. For those of you who may not know, this probably won't surprise you, but I do it by challenging assumptions everywhere I go. And not just other people's, my own assumptions about what is appropriate and what is professional and what is leadership, and doing it regularly in order to make sure that I am being as curious as I'm asking other people to be. It's my way of reminding myself moment to moment that this is just as much my work as it is anyone else's. And in doing that, it allows me, sort of like Ed said, it gives me a bully pulpit. It gives me an opportunity to maybe introduce ideas in places they wouldn't have been if I hadn't bothered to open my mouth. And it may not always be the most politically expedient or a professionally expedient thing to do, but it's the thing I feel called to do because I'm committed to this work. And so that's how I'm choosing to show it up.
Melanie, what about you? I don't want to put you on the spot, but I know that you have some thoughts on this.
I always have thoughts, but one, I love what everyone has said. One area where I'll take it a little bit differently is also making sure that I'm not the only one in the room or that's going to have seats at the table. So leveraging my leadership position to invite others to be inclusive of other voices, and then building the pipeline of those coming behind me so that they can also continue to carry, I don't say the mantle, but to continue to be advocates and voices in this space. I think, we so often just think about our role, but, the organizations that we're sitting on as professionals, professional organizations and our own companies and the like, what are we doing to ensure that we're increasing the diversity within the Food and Drug Law bar? What are we doing to ensure that we're increasing diversity within the public health field? And how are we then leveraging those diverse perspectives in the work that we're doing to create a sustainable model so that's not one and done? So that's just one idea.
I really like that. And you make me think about the importance of normalizing conversations. And that, even just having this conversation, putting these ideas out there, using the words systemic racism and social determinants of health and diversity, equity, and inclusion, that they're not just, random words. I mean, they have substance, right? And they have meaning. And the only way that we're going to get to a point where people are comfortable with them is that we keep having these conversations. And sometimes we might have to make adjustments to have these conversations with people who are a little bit more resistant, but we've got to keep doing it. And so I think that is one thing I would say as a takeaway is, if you're in that spot where you can speak to this and it's something you're comfortable doing, keep doing it. And that's the only way that we're going to start to have a more normal national conversation on how we address racism in healthcare. And who do we still have on with us? Sam, are you still here?
I've been thinking a lot about everyone's comments. One of the things that we think about a lot within the public health law program is, how do we build capacity for people working in public health, but also working in legal settings? That's one of the reasons why I focused on those areas so much. And that means thinking about how and helping to expand the use of language that helps people to make the connections between law and health, and law and health and equity. And that idea of sort of capacity building the capacity of people working in professional contexts, but also working outside of professional contexts is something, I think about a lot. And it is, I think it's an important area of focus, right? Like, where should we be making sort of intellectual and conceptual and practical investments in people and in their understanding about how they do this work and how they engage with these ideas, right? That's how we make change. We invite people into conversations, but we also build their capacity to then start conversations elsewhere and to make changes within their institutions. And so from our perspective, it's what we do within public health practice, but you can imagine that being important in lots of other sectors as we continue to have larger conversations about equity.
I want to ask my fellow organizers, Yvonne, Rukaya, Drew, Myra, when we started this out, and as we've gone through the planning process, what is it that you hoped people would take away from today? I see the wheels spinning there. Fun.
I would say I'll hop in real quick. That what I wanted is to bring in a diverse group of people to begin to talk about these issues in ways that that raise the voices of community, but just from different perspectives, right? And so we've had people from government, people who work within hospital systems, govern hospital systems, people who work for the government, and just talk about the ways that racism, discrimination shows up and the things that we need to do to address it. And for me, I think the last point was just to ensure that as we talked about race, that we also would bring in other issues, right? That other issues around disability, about sexual orientation and gender identity, because those intersections, right? So Black trans women, Black disabled are never discussed in these discussions about racism or lack of access to health. And so that's why I wanted to bring in the people that we did to begin to think about it and move past where we are right now, which is just beginning to identify structural racism and systemic racism from the perspective of maybe a Black man and a Black woman, but not going beyond, right, to where we need to go to get true equity. So I'll stop there.
Anyone else want to add, Bon?
I will say that what I wanted out of this was to expand the idea of what health lawyers like myself might think our role is in this work. And to invite us really to think past, solving the Stark question, to really engaging in health equity work, and that we actually do have a lot more opportunity to be of greater influence than we may take advantage of, and to learn from people who are in other disciplines or in other parts of the industry about how we might be able to do that. So we're less afraid of it and more willing to maybe take it on. And so that was what I wanted out of this, was to really just introduce the idea to myself and my colleagues that we are more than, interpreters of Stark, that we have a much bigger role that we can play if we choose to do so.
I guess I completely agree with what Vaughn just said, and that was sort of trickling around in the back of my mind. And I also really wanted to hear what I heard today, particularly from Dean Matthews, which is calling out what we know to be true. We know that vaccine hesitancy does not equate to Black people being paralyzed by tales of Tuskegee. We know that we need to face the inequities and the racism in the system today and grapple with people's challenges and limitations today. And for her to label the phenomenon of white people getting access and getting vaccines in numbers outstripping the effect that this horrible, horrible virus has on them and their community, and calling it white supremacy, is, to me, what will empower these conversations to continue and to go into the future. Because to Vaughn's point, many of us in our sort of daily laboring are so tunneled in our vision. And in fact, we don't need to be tunneled. But this day and hearing from our esteemed panelists has shown us a way in which we can open up the tunnel, open up our vision, and really have an effect on change. Not necessarily as leaders, because clearly we don't all have to lead. There have to be some followers as well, but in really understanding different ways of extending our experience, our learning, our connections that we all have. I go to church I live in a community. All of those things count. And that's what we've heard today.
So I'm going to offer up one last opportunity for any closing remarks, and then we're going to conclude our time together. Anybody else want to add anything? I think it's been what has not been said, right? I mean, we've had such a great discussion. It's been really rich. We've heard that a couple of times today. And so I just want to say thanks again to everyone who's participated. Thanks to AHLA for the opportunity to do this and to work with such great partners in putting this together. And I'm going to turn it over to David Cade to close us out.
So Don, I want to thank you and thank everyone. I think you said, what else can be said? I think a lot more can be said. I appreciate the amazing sharing that we engaged in today. And for me, this is another beginning point, another opportunity to open the door and to embrace the comments that have been shared and see how we can amplify the voices that have been shared today and carry this message even farther. To Vaughn's point, those of us who are lawyers or whatever discipline you're in, that is your discipline. And from a lawyer's point of view, I think the takeaway is, as a business partner, we have a greater voice than what to do with a stark problem. I think that amplifies your point. The interdisciplinary, multidisciplinary approach to bringing our voices together in this professional realm, I think will allow us to extend our collective goals beyond this convening and beyond even the next convening. So to that, Don, I would say there's more to do, and we're happy to be a catalyst in the voices that came around today, and we will happily take the reins of continuing the sharing on beyond today. So I want to thank you all for participating. It's been rich and rewarding, and I hope you all got out of it as much as I did. So I applaud all of you for putting this together and for spending the time with us this afternoon. Thank you.